speakers, sponsors, administrator, and audiovisual personnel so that we will enjoy another fantastic webinar. May you grant special blessings on all the attendees and their families and stimulate them to give their best in caring for others through you, Almighty God. All these we ask through our Lord Jesus Christ in unity with the Holy Spirit. Amen.
Amen. Thank you, Dr. Henry Dawkins, for such a wonderful and totally enfolding, encompassing prayer for us this morning, setting us off on the right tone at the right time. I now welcome Dr. Seni Onenuju, President of the Caribbean College of Family Physicians Jamaica chapter, to bring greetings from the local chapter and to give a concise overview of this morning's activities. Welcome, Dr. Onenuju.
Dr. Odeniju, we're not hearing you. I see that you're unmuted though. Perhaps you have something plugged in. Still not hearing Dr. Brown Morgan. Are you hearing Dr. Onanuju?
No, I'm not hearing.
No, not hearing. All right. May I recommend let us move on. I'll get in touch with Dr. Onanuju and we'll, once we've sorted out her audio, we'll allow her to bring her greetings again.
Okay, then. So it is now going to be my pleasure to introduce Professor Marshall Toller-Reid, Professor of Epidemiology and Endocrinology. Dr. Marshall Toller-Reid hails from a very prominent Jamaican family, which produced three excellent physicians, well known to the Jamaican and Caribbean medical fraternity. From this trio, we welcome him today as our first speaker this morning. Dr. Toller-Reid is a physician and endocrinologist and the current director of the Caribbean Institute for Health Research Care at the University of the West Indies. He is a graduate of the UWI Mona MBBS program and obtained his master's in philosophy in epidemiology from the University of Cambridge some years ago in 1977, followed by the DSc in epidemiology from the Netherlands Institute for Health Sciences in 2003, and so many other places, Howard University, where he did his training in internal medicine, and subsequently joined the National Institutes of Health Inter-Institute Endocrinology Training Program in the year 2000. So he has been through clinical centers in Bethesda, Maryland, and subsequently in the NIDDK branch in Phoenix, Arizona. Dr. Toller-Reid was certified by the American Board of Internal Medicine and in 2000, and endocrinology, diabetes, and metabolism in 2002, and became a fellow of the American College of Endocrinology in 2005. He joined the staff of care in 2003 and was elevated to the rank of Professor of Epidemiology and Endocrinology in 2014. And that same year, he was appointed Director of Care's Epidemiology Research Unit and became, I think he was appointed Director and became, I think, a bigger role. I'll have to find out what that was in 2020. He's well published. Dr. Toller-Reid, what happened in 2020?
Besides COVID, institute
Yes.
director, institute director stepped down.
Yes. Oh, wow, yes. So I was telling them that you're very well published in the areas of obesity, diabetes, cardiovascular disease, and prostate cancer. So we want to welcome this most affable, charming, and often very self-effacing gentleman and professor to speak with us today on advances in endocrinology in women's health. So welcome, Professor Marshall Tullereed, and over to you now.
Yes, thank you very much, Dr. Brown Morgan, for that introduction and the other parts which weren't on the introduction I sent. Yeah, so this is an interesting session because I actually started with one topic in mind. And when I looked at the agenda again for a second time on Thursday, I realized that the topic I had in mind had already been covered by another speaker. So I had to, as they say in Jamaica, wheel and come again. So I looked and I said, I think one thing might be missing. And so maybe I'll focus a little bit on that today. Because even though it's a sort of emerging area in endocrinology, and I'm sure that you're going to get a lot of updates on so many other areas during the course of the day. I think you just have to be excited and wait for each presenter. I thought I would talk about the CKM issue. This is a sort of new concept. It's, well, yes, relatively new, sort of put forward about a year and a half ago, really around understanding a little bit more about the link between cardiovascular disease, kidney disease, and metabolic syndrome. So let's see if I can move my slides along. So we're going to talk about the cardiovascular kidney metabolic syndrome. And I think even though it's not really something that has been well described in Jamaica, I think it really is going to be emerging as a significant endocrine issue in women, particularly because of the distribution of a number of these risk factors and the fact that we are seeing where this condition does increase the risk of premature death, particularly for cardiovascular disease. So it really does begin to link together a number of the things we've been observing in our clinical practice. I'll talk a little bit about why the American Heart Association has promoted this concept of a CKM syndrome, not CKD syndrome. And we'll talk a little bit about some of the treatment options, which might bring you into some of the advances in endocrinology. But I think there are a lot of the issues that you've heard about, but it will explain a little bit more about why we may be choosing some of the newer agents in helping to reduce risk. These are data from the third Jamaica Health and Lifestyle Survey. This was completed in 2016-17, and actually currently the department is getting ready to do the fourth Jamaica Health and Lifestyle Survey in collaboration with the Ministry of Health. They're not out in the field, so if you have patients who are approached, you can tell them it's not a scam. They actually are going to be reaching out to try and identify some of these health issues in Jamaica. But one of the things that you see here is the prevalence of obesity measured by the body mass index, and it shows a breakdown by age and sex. And you see a number of slides from that survey which look at a number of these risk factors by age and sex. I think the thing that you'll see most prominently is that the prevalence of obesity is a lot higher in women compared to men. And I'll come back to that point as we talk about this CKM syndrome. In fact, by the time you reach about middle age, you're looking at more than half of the female population being in the obese category, not overweight, obese. And the last survey, what we found is that the median BMI for Jamaican women was 30, meaning that 50% of all women are in the obese category when we do their height and weight. Other risk factors that we looked at included hypertension. One of the things that you will notice here is that while you're not having the striking differences in the prevalence of this condition by sex, what you are seeing is that by the time people are in their 50s, you're looking at nearly 3/4 of the population having some form of hypertension. Diabetes follows a pattern a little bit more similar to what we saw with obesity, with a higher prevalence of diabetes in women. And it's not surprising because we are seeing where obesity as one of the drivers of diabetes is high in women. And so as we move into the older age groups, we begin to see that separation in the prevalence of diabetes with a higher burden in women compared to men. Um, this is a paper that we're actually just about completing now, and it should be published soon. This is on data from the Jamaica Health and Lifestyle Survey. This is the first time that we've looked at kidney disease on a national level. This is being written by Dr. Fisher, Laurie Fisher, and what she has attempted to do is look at the prevalence of kidney disease based on persons who gave both urine and blood samples for the study. And so kidney disease is defined as the presence of proteinuria, albuminuria, or a reduction in the glomerular filtration rate. And based on these data, while we're not seeing any sex differences in the prevalence, you can see that there's a fairly high prevalence of chronic kidney disease in our population, with about a third of the population that's over 50 having some form of chronic kidney disease. This is put in the context of what is happening in the region, and these are coming out of PAHO's latest NCD at a glance report for 2025. And I'll be showing you a couple of slides that I've extracted from that presentation, where it actually looks at the burden of a number of non-communicable diseases by country. And what you'll see here, you might see your other countries, if those of us who are joining from overseas might begin to look for their countries. But where you see Jamaica is really at the top for premature mortality from NCDs. And while the prevalence in men is higher than what you see in women, Jamaica is considered number 2 after Haiti when it comes to mortality. The second slide is looking at the cardiovascular disease death rates. Again, Jamaica comes up number 2. The prevalence of cardiovascular disease mortality in men is higher than it is in women. So you see these two symbols at the top. The men are in blue, the women are in the purple. And then when we look at the next slide, which focuses on diabetes, you'll see that Jamaica has the highest prevalence of mortality from diabetes, and that there is not really any sex difference when you look at those mortality data. So emerging out of this, we're beginning to see where there is a sort of bigger picture that we need to be mindful of, and that we need to begin to see how a number of the things that are happening are integrated in what we're seeing in the final outcome, which is mortality. And I mean, there may be other ways of measuring the impact of this condition, but we don't really have a good handle on other things like the rates of heart disease and so on for Jamaica, unlike Barbados. So the American Heart Association promoted the concept of the cardiovascular kidney metabolic syndrome a couple of years ago. And this is because they're beginning to recognize that it's a disorder which is resulting from an interaction between the metabolic risk factors that we've been accustomed to measuring, the blood pressure, the cholesterol, the obesity, kidney disease, which is becoming more popular, and also how those two things are linked to the cardiovascular system, because there is an interplay between both of these things. And then these conditions, when combined, are leading to a number of issues in terms of how different diseases will manifest themselves. And of course, the main concern that we have is over whether it results in premature cardiovascular outcomes. And so it's a way of pulling together the endocrine and cardiovascular and the renal, because you're now looking at the relationship between obesity, diabetes, chronic kidney disease, cardiovascular disease, and this includes a full gamut of cardiovascular disease because we are looking now at things like heart failure, which is becoming increasingly common, atrial fibrillation, especially with our aging population, and not just the traditional heart disease, stroke, and peripheral artery disease that we often focus on. This is a schematic. This is a schematic that talks about how everything is linked. And why I'm kind of putting a lot of the emphasis on the obesity, and particularly the obesity figures that we're seeing for Jamaica now, is that the CKM syndrome is really thought to be a result of obesity, that obesity is a primary process that drives a lot of what is happening. So they talk about whether you have excess obesity, which could be measured by just your weight or your size, but they also talk about dysfunctional obesity, and this is really talking about excess amounts of obesity in the wrong places. And the focus very often is on the visceral fat, which is the fat which is around the abdomen and below the muscle. So it's not the fat that you will feel, but that in itself is the sort of primary driver. And that fat tissue results in the production of a lot of inflammatory markers. And we think this is really what begins a lot of the issues that we're seeing when it comes to these three conditions coming together. So the inflammation and the oxidative stress results in a worsening of the insulin resistance. So it means that your body is less sensitive, and also those processes are resulting in vascular dysfunction, and vascular dysfunction may be the very early things that result in atherosclerotic disease, as well as the beginning of your vascular stiffness and heart failure, resulting in heart failure and other conditions. And we know that it can do this directly through the production of these inflammatory markers, but also when these inflammatory markers are elevated, it increases the risk of hypertension. It results in a dyslipidemia, which is a typical metabolic syndrome that we talk about, with a low HDL, high triglycerides, high blood pressure, and you're beginning to see dysfunction in terms of glucose control. The obesity itself is also driving other processes at the same time, which we're becoming increasingly aware of. And that is that the obesity drives an increase in your glomerular filtration rate and begins to set up glomerular sclerosis taking place within the kidneys. So this actually is now where you begin to see a number of the interactions taking place between the heart and the kidney, because we know that they're interrelated. So the blood pressure is going up. There is sclerotic disease. The sclerotic disease in itself is going to result in increased blood pressure, and that in itself is going to add to the cardiovascular burden. We know as well that there are neurohormonal responses that are taking place in the kidney whenever there are issues with blood flow and also access to adequate flow. And this in itself can be exacerbated by issues that are starting in the heart. So we know that the kidney is sending signals to the heart, but if there are issues with the heart, and we see it very commonly when we're treating patients who have heart failure, or we put them on certain drugs and we see the potassium going up or the creatinine going up. This is really just showing you the link that is taking place between what is happening neurohormonally and in terms of the vasculature when it comes to the kidney and the heart. So these two things are interacting, with the kidney disease increasing the risk of atherosclerotic disease, changing how the heart functions, increasing fibrosis because of the elevated blood pressure, the neurohormonal activation that is taking place through the renin-angiotensin system is also contributing to how the heart is functioning. And then the liver. The new concept about metabolic disease, because right now what they're seeing in America is that what we used to call traditionally fatty liver is becoming the leading cause of hepatic failure. And this is driven a lot by the presence of just this inflammation, which is resulting from obesity. So you have ectopic fat deposition leading to mold syndrome, and then of course it exacerbates inflammation that takes place. It also contributes to the dyslipidemia. So this is how everything is coming together as a picture. Now I'm going to kind of just talk a little bit about the CKD because sometimes that's not something that we pay a lot of attention to, but I just want to bring that up because it's one of the things that we use to identify and stratify persons with chronic kidney disease and rank them when we talk about how the CKM classification goes. So remember, for kidney disease, chronic kidney disease, it can be either a dysfunction related to filtering. So we measure how the kidney filters through the serum creatinine. And remember, of course, with the serum creatinine, it's very important that we calculate the estimated glomerular filtration rate because the serum creatinine can be misleading if we only look at the value and don't do that calculation. So it may look all right, but when you do the calculation, you realize that the eGFR is 40 or 30. And that's a very different picture than thinking that you have a patient who has a normal filtration rate. But it's not just about filtration, it's also around evidence of dysfunction taking place as measured by proteinuria or albuminuria more specifically. And one of the reasons why there's an interest in measuring both of these parameters is the recognition that when these are abnormal, the risk of adverse outcomes, not just the risk of developing kidney failure, but also premature mortality and cardiovascular disease is increased. And what I want you to pay attention to in this slide is that as the kidney function worsens, so in other words, when you get your GFR below 30, this person now moves into a high-risk category. But the GFR does not have to go down to 30 for you to begin to believe that the person is at high cardiovascular risk because their risk is increased, yes, once your GFR is going in that range, but also once proteinuria is also associated with that reduced GFR, you're looking at a much higher risk person. So what you will notice is even if you have microalbuminuria, even before your filtration goes below 30, you're already in the high risk category. And if you have gross proteinuria, meaning that you're spilling more than 30 milligrams per millimole in your urine, you are already at high risk once your GFR is going under 60. So traditionally, we have always focused on the metabolic syndrome. And the metabolic syndrome has looked at two things. It looks at the obesity, the blood pressure, and the cholesterol, as well as the glucose. This is what we've traditionally been working with. And there's really not any change in terms of how we've been thinking about metabolic syndrome. Primarily, we thought about metabolic syndrome around whether it increased the risk of diabetes, whether it increased the risk of heart disease. These were the two things we were concerned about. We know that when the HDL cholesterol is low, or your triglycerides are elevated, or your blood pressure begins to go up more than 130/85, or your fasting sugar is more than 5.6, your risk of these events increases. And there's always been a lot of controversy around how we measure obesity. Traditionally, we've looked at the waist circumference because we're interested in the central adiposity a lot more than the general adiposity. And there's been a lot of back and forth on the cut points that we should use. I am just going to use what is put forward by the US population, although they have recognized that for Asian populations, these cut points need to be much lower. As you can see, for the Asian population, they're looking at in men a waist circumference of more than 90 or women a waist circumference of more than 80. But for everybody else, they're using the 102 for men or the 88 for women. But CKM now throws into the mix other issues. So it's not just the things that we've traditionally been measuring, but also asks us to think about whether we're identifying persons who might have chronic kidney disease. So it means now we're adding to the mix whether or not we are recognizing any impairment in renal function or proteinuria, and also recognizing that heart disease may begin a lot or be present a lot earlier than we had anticipated. And with the changing medications that we have available, we can begin to pattern our treatment to begin to address some of these risk factors in a more proactive way. So the CKM syndrome has 5 stages, starting with stage 0, which is really around persons who have normal weight and who also do not have any of these risk factors. So they're not hypertensive, triglycerides in particular are not elevated. They don't have features of the metabolic syndrome. They don't have diabetes. There's no evidence of chronic kidney disease, and they have no evidence of subclinical or clinical cardiovascular disease. And I'll talk a little bit about the subclinical cardiovascular disease estimation or measurement. You have stage 1 CKM. If it is, you have excess obesity or dysfunctional adiposity. So when we talk about excess obesity, we're looking at the body mass index, 25 in the case of everybody except persons in Asian ancestry, that is Indian or Chinese. We realize that their risk increases from the time the BMI gets about 23. And then an elevation in the waist circumference. So you can use the waist circumference as your measure. And we saw the criteria, 88 centimeters for women, 102 for men. But if you're Asian ancestry, 80 and 90. So Indian, Asian, 80 and 90. But the dysfunctional adiposity is measured by changes that are taking place in the blood glucose. So if you have somebody who has prediabetes, measured by the fasting glucose, or fasting glucose, which is no longer in the normal range, that is considered a person who is overweight and has that is considered to have dysfunctional adiposity. Now, when other risk factors begin to emerge, you're moving into stage 2. So it means that if you've gone on to develop diabetes or hypertension or the components of the metabolic syndrome, or there's evidence of chronic kidney disease, either measured by a fall in your serum creatinine or albuminuria, you are now moving into stage 2. Stage 3 means that in addition to those risk factors, you may have evidence of subclinical vascular disease or subclinical heart failure. Subclinical vascular disease, meaning atherosclerotic cardiovascular disease, which are the traditional things we think about, the heart disease, stroke, etc. Subclinical heart failure is now also being added to the mix because we now recognize that there are medications that can change the trajectory for heart failure. So how do we recognize if there may be this high risk, or if you're dealing with somebody who's at high risk? It's now calling on us to think more carefully about whether or not vascular disease is present. The tests that have traditionally been promoted for detecting early vascular disease, and which has been pushed forward by the American Heart Association, is the coronary calcium. There are other things they've been measuring, like the carotid intermediate thickness, etc., but the strength of that relationship and whether it should suggest an indication for cholesterol therapy is not as strong. So the recommended way of identifying subclinical vascular disease is the use of your coronary calcium. You may identify it as well in patients who may have these procedures done, like an angiogram, either the regular coronary cath or the CT angio, which may also identify the subclinical vascular disease. But if you're going to look for it, primarily the suggestion is to use the coronary calcium. Subclinical heart failure is a lot more common than we think. We may pick it up from the echocardiogram because we're looking at things like the ejection fraction, how well the heart is contracting. But the use of these new biomarkers, the proBNP, if it's elevated, or some of the troponins, are markers that we can use now to identify whether people may be having subclinical heart failure. We can also recognize that they may have, maybe in this high-risk category, if they're in the very high-risk CKD groups, meaning that the eGFR is now going under 30. That is a very high-risk person. Or if you use a grid, which shows the relationship between the EGFR and the protein, and you're seeing them falling in that red band from the grid. They are in a high-risk category. You can put them in that basket without doing anything else. Also, if you don't have access to some of these tests, meaning that if you're not, and we know that access to the coronary calcium is not really very accessible in Jamaica currently. There are cost issues related to some of these biomarkers or even access to echocardiography, but we can use the risk score, the ACC risk score, to see if you have a patient who has a very high cardiovascular risk, because that person will be treated just the same. And that is a calculation that is based on the blood pressure, other cardiovascular risk factors, and the lipid profile, as well as age, sex, and other demographics, to see whether or not your patient is at high risk. So even without some of these imaging studies, you can risk stratify your patient and decide where you are with them. And finally, once we are satisfied that the person has some form of cardiovascular disease, a heart attack, a stroke, whether they're going into kidney failure or not, we are putting them in stage 4. So once the event has occurred, they're in stage 4. So this is really what CKM is about. Why it becomes a lot more relevant is that the thoughts around the interrelationships between all of these conditions are going to be influencing the choice of treatment. And this is a schematic from the latest American Diabetes Association guidelines on management or pharmaceutical management of hyperglycemia in patients with diabetes. What you can see here from the very beginning in a patient with diabetes, the first thing they want to ask about is, does this person have a high risk of cardiovascular or kidney disease? Because now with the new treatments that we have available, we can select agents which can change the natural history of these two conditions. So once there is either atherosclerotic disease, if they've had a heart attack, a stroke, or something that tells you that this person has cardiovascular disease, they are saying you need to move for a therapeutic agent which will have cardiovascular benefits. And the two that have been shown to improve the risk of cardiovascular outcomes are the GLP-1 agonists, which are your incretin therapies, and your SGLT2 agents, which are working through the kidney. When it comes to heart failure, if you have your patient who has heart failure and has diabetes, and SGLT2 has to be part of the mix, because we know that the SGLT2s will reduce the risk of that condition. And then when you have a patient with chronic kidney disease, either early based on a reduction in their filtration rate or the presence of proteinuria, we are looking to see, can I add an SGLT2 inhibitor to this patient's regimen? And there are also some GLP-1 agonists which may also be helpful. So these are ways in which we can address the whole syndrome. We're addressing the blood sugar, but we're addressing everything at the same time. The other area which is of concern is coming right back to the weight issue, because if we believe that weight is driving a lot of these metabolic abnormalities, we need to address weight as well. And again, in choosing treatments, we're saying, is this person overweight? We need to bring the weight down. We try to avoid medications that will increase the risk of weight. We try to support them with medications which have been effective in terms of weight loss, and that we will address these with the choice of medication based on these factors. Hypertension is a very big risk factor for cardiovascular disease and is a big component of the metabolic syndrome. We're defining high blood pressure now as a blood pressure more than 130/80, not the 140/90. And all the data now is suggesting that the lower we get the blood pressure, the better. Blood pressure now becomes part of what patients should begin to do or have measured. And we're currently doing a project, so I'm always talking about blood pressure now, because one of the things that we have been discovering is that the method that is used a lot of times in our practice is inappropriate for getting accurate blood pressure measurements. So this is a schematic I like to use a lot of times, really around how we do the blood pressure. A couple of things. This one is from the CDC, ensuring that people have not eaten or had anything to drink for at least 30 minutes before doing the blood pressure measurements, that they should not be doing the blood pressure measurements when they need to urinate. When they're doing the readings, they should be seated with the back supported. They should not be talking at the time. The arm should be at the level of the chest. Ideally, the cuff against bare skin, and the feet should be flat on the floor. And these are all factors that will impact whether we get an accurate blood pressure reading and we don't overtreat our patients. I'm going to just shift for a brief moment to this video because in addition to the readings that we do in the office, there is a lot of emphasis on readings done at home. So I'm going to let you watch this one. I give my patients all the time because this is what they are asked to bring to the office for me to look at if we're having things around what is going on with blood pressure. All right, let's see now if I can find it here.
A real talk about blood pressure. Do you monitor yours regularly? It's something everyone with high blood pressure should do, but it's something most people don't know how to do correctly. Checking your blood pressure regularly will help let you know if you have it under control. It will also help you start to understand which factors are putting you at high risk for stroke and heart attack. Before I get to that, though, I just want to stress one thing. If you have high blood pressure, you should talk to your doctor to figure out how frequently you should be checking it at home. For most people, taking your blood pressure twice in the morning and twice in the evening, even just for a week, will help you and your doctor get a better understanding of your blood pressure. For morning readings, it's best to take those before you take your blood pressure medication. It's also very important to avoid exercise, caffeine, or tobacco at least 30 minutes prior to testing. This dose can affect your levels. Now, let's move on to talk about the proper way to measure your blood pressure at home. Nearly half adults in the U.S. have high blood pressure and are at high risk for stroke and heart attack. So self-measuring is one of the easiest ways to be proactive about our health. Here I have my blood pressure monitoring device. It's easy to use and it helps me get an accurate reading. Be sure to get an automated device with the upper arm cuff. That's the type doctors recommend. The first thing you want to do is find a quiet place to sit where your back is in an upright, stable position. A dining room chair is great. You want to make sure the chair isn't too soft so your body is fully supported. Sit with your feet flat on the floor and don't cross your legs or ankles. If you need to use the bathroom, make sure you go before you do your reading. Next, rest your arm on a flat surface with your palm facing up. Place the blood pressure cuff on your bare upper arm just above your elbow. Your arm should be relaxed and resting so the cuff is at the same height as your heart. Now rest quietly for 5 minutes before taking the first measurement. Avoid talking while taking your blood pressure measurement. Once your first measurement is completed, write down the blood pressure numbers and pulse that are displayed on the device. Wait 1 minute and then repeat this process again. As you just saw, it's important to check your two measurements at around the same time each morning and evening. At your next doctor's visit, be sure to share your blood pressure numbers so you can discuss the numbers and so your care plan can be changed if necessary. That's it. Not bad, right? Measuring your blood pressure at home is easy to do and a great way to stay on top of your health. If you have more questions about managing or measuring your blood pressure overall, visit the website.
Okay, so I think let me see if I can find my presentation again. Let's see. Yeah. Okay. All right, let's see if I am where I should be. It's okay, that's not what I wanted. Okay, let's see, resume slideshow. Yes. All right.
Big dreams start small.
Okay, all right,
From
let me
getting
stop
domain
this.
to creating your website, email, and online security, we've got you covered. You don't need to be a tech expert.
Okay, thank you, YouTube, without advertisements. With advertisements. All right, let me get back to my Zoom screen share. Okay. All right. Okay. All right. So we spoke about the measurement of blood pressure. So blood pressure measurement again, and the blood pressure control is important. So we're looking at things that we can do. And when they talk about the cardiovascular kidney metabolic syndrome, they really talk a lot about other things. So people often say that we focus only on drugs, but they often focus on a multidisciplinary approach to help to manage weight and other risk factors. So other risk factors which would be important include things like eating in terms of increasing our potassium intake, reducing sodium intake, reducing alcohol, stopping smoking, and being more physically active. But there are specific medications which have benefits when it comes to cardiovascular outcomes. So the ACE or ARBs are helpful. Beta blockers may be used when you have a history of coronary disease or some types of heart failure. And if you have patients with diabetes, we know the benefits of the SGLT2 inhibitors that might be very helpful. If sometimes none of these issues are present, then a lot of other blood pressure medications can be as helpful. So it doesn't have to be specifically those, but those are specific ones that give benefits for cardiovascular risk. Lipid lowering becomes more important. For those with very high risk, we're looking at high intensity statin therapy to get LDL cholesterols down a lot more than we think. And even for those who have established disease, especially in the setting of diabetes, we're looking at getting those LDL cholesterol levels down to as low as 1.4. And this is just a listing of what we consider high intensity. So when we're talking about high intensity statins, we're talking about atorvastatin and rosuvastatin at doses of 40 to 80, or in the case of rosuvastatin, doses of 20 to 40. That's what we're talking about when it comes to high risk. Moderate intensity is some of those statins at lower doses, or some of the traditional statins, simvastatin, pravastatin at higher doses. Aspirin therapy is become a little bit more controversial because there are risks and benefits. So we tend to use it primarily in persons with established heart disease and talk about the risks and benefits when it comes to people who don't have established heart disease, including those with diabetes. So in the last round, how do we address some of these issues? So there's a treatment plan which is again related to what we spoke about with the therapies available. Early stage CKD, we want, or stage zero CKM, we want to make sure that there is an ideal cardiovascular health, meaning that we look at a number of risk factors: sleep, smoking, physical activity, diet, and healthy weight, exercise. All of these things are part of your preventative strategies for persons who do not have excess obesity or evidence of dysfunctional or excess obesity. Once there is excess obesity, we know that weight loss can help to reduce the risk of some of these issues. And so there's a lot of emphasis on lifestyle interventions that can promote weight loss. We know that if people lose between 5 to 10% of their weight, there are changes or benefits to their risk of diabetes and blood pressure if it's not present. So they revert. It takes a higher amount of weight loss to produce cardiovascular benefits. So you're looking at more than 10% in reduction in weight to see cardiovascular benefits. And then this is a stage where we can begin to have that conversation around the use of other agents that can help to promote weight loss, including our GLP-1 agonists, which are now indicated for treatment of obesity, and even metabolic surgery, or what we consider bariatric surgery, if we feel like this is something that is needed to help to reduce risk. Now, when they move from obesity to developing the metabolic risk factors, and there is presence of chronic kidney disease, we are now looking at saying, okay, how are we going to manage these risk factors? So if you have a patient who is hypertensive, you're looking at getting that blood pressure down using ACE or ARB therapy. If the triglycerides are high, you figure out why that's happening. You can use statins in the case of mild cases, but you may need more direct treatments if the triglycerides are high. If they have the metabolic syndrome, the lifestyle things that are related to reducing a risk of diabetes will work. If the person has diabetes, you think about whether the indications for use of SGLT2 inhibitors or your GLP-1 agonists, and manage all of those risk factors, including blood pressure and cholesterol aggressively. And in the case of patients who have chronic kidney disease, we know the role of the SGLT2s in particular, very helpful there. Some GLP-1s and some of the new mineralocorticoid receptor blockades agents are also very helpful. When it comes to persons who have gone on to develop subclinical cardiovascular disease or who have developed chronic kidney disease, or who we feel are very high risk for cardiovascular disease based on their risk score, we need to now begin to be very aggressive around things like statin, identifying cardiac function and ensuring that they're on appropriate medications, and seeing if there are opportunities to add SGLT2 inhibitors. Remember, these are not just limited to diabetes now. And then, of course, once the person has developed kidney disease or heart disease, we're going to be managing all of those things according to the protocol. So the final slide is really just making a point around everything coming together. So very often we focus on our patients and their practices, behaviors, and so on, but we recognize that there are other things that are taking place at other levels, which we also as physicians need to advocate for. We know the role of things that are happening, not just at the individual level where we talk about, what is your behavior and how can you modify your behavior to address certain things, but we know that there are other things that are happening in terms of how people relate to each other, which can worsen our cardiovascular health, things that are happening in the community, how we're building. Those who are stuck in the water on Friday, we'll have a different discussion on that, but even things like air pollution and other things that can impact what is going on. And then at a societal level, where we're looking at how well are we doing in terms of providing what the economy needs, or education, addressing social needs and healthcare. These are all part of tackling this cardiovascular, kidney, metabolic health issue. And as we begin to look at this issue, we want to begin to understand what's happening in Jamaica and understand a lot more, particularly about how it's going to be impacting our women and how it's contributing to the data we're seeing regionally, with Jamaica having one of the highest NCD mortality burdens in the region. So thank you for your attention.
Professor Tollereid, I don't even know how to respond to what you've just presented. Well, first of all, let me just correct something. There are 4 Tollereids, not 3, 4 Tollereids, okay? I didn't forget Desiree. I didn't.
Okay, good. I know she would.
One female, yes, and they're all great. Absolutely great. So I just want to thank you for your presentation. But I also think you've brought us a whole, well, you've enlightened us, but you've brought us a whole basket of bad news.
Oh,
But Jamaica,
yes.
where we are in Jamaica, I can only hope that we, I'm looking forward to this 4th Jamaica Health and Lifestyle Survey that's coming out, because we need to understand why the bad news is happening here for us here in Jamaica. Why are we so blighted in the Caribbean as to be at the top in all these areas of death from all these chronic diseases? And based on what you're saying this morning, literally 2/3 of the population who are mature individuals probably have the CKM thing going on.
Yes.
And how do we really prevent it rather than having to deal with that whole plethora of treatment? It is something for us to really, really take note. Thank you for introducing us to this concept, to the general practitioners, family physicians, to the concept for those who hadn't heard too much about it. I heard a little about it before. I realized it's something that is new and that we need to know more about it, because it's going to impact on every aspect of our management of our chronic diseases and so forth. But Prof, come with some prevention. Come with some
Yes.
prevention.
We're trying,
Thank you
we're
so very
trying.
much.
All right, thank you.
Thank you so very much. And we're going to take questions later on. I don't know if Dr. Onanuju is ready for us now.
Dr. Onanuju, are you there?
I hope I don't know if you
Yes, you are. We're hearing
Yes.
you.
are
Okay.
you
Hearing you, Dr. Onanuju. You go ahead now.
very much. Good morning. First of all, before I start, special thank you to Dr. Marshall Toloreed. I asked him, I didn't expect a yes, and he did his work as usual from I knew him as a little boy until he became a doctor, until he's now a professor. And he's really giving us a very detailed, comprehensive presentation. Thank you very much, Dr. Toloreed. Professor Toloreed, my apologies. All right. Good morning, everyone. To our specially invited guests, Professors Marsha Toloreed and Karen Carpenter, Doctors Guy Anchana, Leo Walker, Karen Phillips, Mark Minot, and Anthony Frampton, esteemed colleagues, our sponsors, Merck and Medimpex Jamaica, friends, ladies and gentlemen, a pleasant good morning to you all. The theme of this morning's webinar is the intersection between physical and mental health in women, exploring the clinical and ethical considerations. During today's presentations, we have a lineup of topics revolving around women's health, ranging from advances in endocrinology, thyroid disorders, diagnosis and management, gestational diabetes, reproductive endocrinology, obesity, and metabolic syndrome. In addition, we will be looking at female sexual dysfunction, osteoporosis, and hormone replacement therapy, while exploring some of the ethical dilemmas that may arise. Women, from the very beginning of time, have played an important and pivotal role in society. Over time, they have ventured out and sought to make their mark in areas traditionally seen as being male-dominated. Their contributions to academia, science, research, business, and entrepreneurship cannot be ignored. Despite their numerous successes and their physiological, hormonal, metabolic, and anatomical differences, we still recognize that their unique biological, physiological, and hormonal differences predispose them to various health conditions and illnesses that can and do affect their physical, mental, emotional, and psychological well-being. And today, we, the members of the Caribbean College of Family Physicians, Jamaican chapter, are fortunate to be exploring some of these. Thyroid disorders are common, particularly among women. Approximately 1 in 8 women will develop a thyroid condition in her lifetime. Obesity has been a chronic health issue for quite some time and continues to be on the rise. Our women are particularly vulnerable because of their naturally lower metabolic rates. This condition with other social This combined with other social factors and unhealthy lifestyle choices increases the incidence of obesity and associated complications, among them metabolic syndrome, which can also be associated with the development of diabetes mellitus, which for some may present beyond pregnancy. Sexual dysfunction is a common problem among women. Osteoporosis is also more common among women than men. Hormone replacement therapy is an effective treatment for menopause symptoms, but it may not be right for everyone. Today, we will be looking at its pros and cons and ethical issues that may arise from its use. Today, the Caribbean College of Family Physicians Jamaican chapter is pleased to be exploring these various topics with you, our valuable audience. As such, we have a lineup of knowledgeable and experienced speakers who will share their time, talent, expertise, and insights with us. Professors Masha Tolori and Karen Carpenter, Doctors Chana, Walker, Phillips, Minot, and Frankson will welcome you all wholeheartedly. A special welcome to all our members, local and regional participants, and all allied health care professionals who are in attendance. A special shout out to the pharmaceutical companies Merck and Made in Jamaica for their support of this event. Also, commendations to Mr. Samuel Heron of Oldgate Solutions, who will be keeping us virtually connected, and to the CCFP Secretariat headed by Ms. Lynn Thompson-Hyatt, our administrator, who works behind the scenes to make it all happen. On behalf of the college, I thank and welcome you all, and I invite you to sit back and enjoy the presentations. Thank you, and as always, God's richest blessings.
Thank you very much, Dr. Seni Onanuju, our president of the local CCFP chapter. Sam, I think we should be going straight into a promotional video at this time.
Yes, that's next. Gonna play it now.
Yes. Okay.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care. The Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global Impact, Regional Action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice.
CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered.
If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians.
CCFP membership offers numerous benefits, including continuing medical education,
professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies,
research and publications,
global connections.
Join the Caribbean College of Family Physicians today, whether by direct membership, by chapter membership, and be part of a movement that is shaping a healthier future for the Caribbean.
Together we can make a difference.
Become a member and make a difference. Thank you.
Good day, colleagues. It's a pleasure to be with you today as we highlight some important information about the Caribbean College of Family Physicians. The Caribbean College of Family Physicians, Jamaica chapter is proud to share a glimpse into the work we're doing to support and elevate family physicians in our island state. Let me begin with a brief overview. The Jamaica chapter is one of the founding arms of the Caribbean College of Family Physicians and currently includes over 300 members, many of whom remain actively engaged. Our chapter plays a pivotal role in both clinical and educational outreach and serves as a cornerstone for continuing professional development, member engagement, and advocacy. In addition to organizing CME activities and professional networking opportunities, we actively advocate on behalf of our members and the broader healthcare community. Our advocacy efforts include collaboration with the Jamaica Tobacco Control Authority, the Heart Foundation of Jamaica, the Medical Association of Jamaica, the Jamaica Fair Trading Commission, and various health insurance providers with whom our physicians conduct business. Through these strategic partnerships, we aim to ensure that the voice of family physicians remains influential in shaping national health policies and standards. Over the years, we've led or partnered in several key initiatives. We have collaborated with JVMA for the annual One Health Conference. Every May, we co-hosted the World Family Doctor Day celebrations with the Association of General Practitioners of Jamaica and the Family Medicine Department at the University of the West Indies, Mona. Our annual event brings together over 900 plus physicians and other healthcare professionals from across the region. Annually, we have organized more than 20 CME sessions, both virtual and in person, on topics ranging from mental health and wellness and ethics in primary care to cardiovascular updates, ensuring our members stay current with evidence-based practices. Additionally, our website has a blog and newsletter platform to highlight family medicine voices across the Caribbean and provide a platform for scholarly work and opinion pieces. We continue to host our own website, ccfpjamaica.com, where information can be easily accessed. We are one of Jamaica's leading professional associations, accredited by the Medical Council of Jamaica, MCJ, to organize continuing medical education, CME, activities on behalf of pharmaceutical companies and other organizations seeking accreditation for their educational events. We have expanded our CME offerings through an on-demand e-form. We actively participate in a range of outreach initiatives, including health fairs, the refurbishment of facilities for persons with disabilities, and the provision of furniture, medical equipment, and pharmaceuticals to homes for the elderly and disabled. These are just a few examples of the impactful work being carried out by our chapter, made possible through the dedication and collaboration of our members and the support of an efficiently managed secretariat. What keeps our chapter strong is our commitment to inclusivity and relevance. We actively reach out to both seasoned practitioners and new graduates through the FAMMed unit at UWI Mona and at our CME conferences. Membership is open to all physicians. There are different categories of membership on our website. Our CME events also offers the opportunity for physicians, nurses, and allied health professionals to gain CME CPD for their annual renewal of their practicing license. We create mentoring spaces, WhatsApp communities, and free access to accredited CME sessions. We also recognize that our younger colleagues are looking for more than certificates. They want mentorship, representation, and purpose. That's what CCFP offers. For the upcoming year, we're looking toward greater initiatives. That is why we are encouraging you to join our organization. New members, new ideas, new beginnings. We encourage our existing members to re-engage as we look towards exciting times ahead for the Caribbean College of Family Physicians, Jamaica chapter. We need you, new members, returning members, and future leaders. A number of our members can and will share with you why they personally joined CCFP. It was the sense of belonging they felt. They realized they were not just a GP in their own practice. They were part of a regional network of professionals who understood challenges, have shared values, and were committed to advancing family medicine in the Caribbean. With that said, we invite you to join us. Not just for CME credits, but for community. Not just for events, but for impact. Because the college is only as strong as its members, and your voice matters. Thank you, and we are happy to speak with anyone interested in joining or renewing their membership. We're stronger together.
Yes, the college is only as strong as its membership and only as strong as those who engage and participate. So we ask you all, the new, the young, those who are members but are quiet, to join and participate. We're growing and we are glowing. There's much that we are doing, and there is more that we can do with your help. So please become active and join. Please appeal, get in touch with Lynn, Mrs. Thompson Hyatt, at the CCFP Secretariat and join. Now it's for me to apologize for the inadvertent absence of our next speaker, Dr. Channa, who is very suddenly and unavoidably absent. And we hope that all is well with him today. And at this point, we will just move on into our next, well, not the presenter yet. We'll just have our gold sponsor presentation by Merck to go ahead, and then we'll go ahead and introduce our next sponsor. So please, Sam, go ahead.
Good morning.
Good morning, Kimberly.
I do want to confirm that you are able to see my presentation.
Yes, thank you. We'll just ask you to go full screen and we're good to go.
Great. Okay. You are seeing full screen now? Yes. Okay, great.
We are.
Good morning, everyone. My name is Kimberly Skyers. I am your medical representative from Merck. My colleague is Charmaine Henton, and between the both of us, we do cover the island of Jamaica. Today, I would like to speak to you or reintroduce to you our Euthyrox brand. We have rebranded it as our Euthyrox new formulation. Merck has more than 124 years of committed, Merck has more than 124 years committed to the treatment of thyroid. We have started in 1984, where there was the introduction of the desiccated thyroid gland of sheep in Germany, and we had the thyroidine from Merck available until 1983. That process went on into 1973, where Euthyrox Mona T4 tablets were introduced in Germany and later in many other countries. In 1993, Merck initiated globalization of its thyroid area, and in 2007, Merck acquired Serono and strengthened its global and scientific presence. In 2016, we have worked very hard to make Euthyrox a worldwide presence in the market of pharmaceuticals. Euthyrox is marketed in more than 100 countries. It is approved by the FDA and the EMA. Merck is a global leader in thyroid disease treatment. Euthyrox new formulation is supported by an exceptional global supply network with 5 production sites and 9 packaging centers worldwide, producing 17 billion tablets a year. We currently have at least 45 million patients in 100 countries, and again, over 120 years of experience in the treatment of thyroid disease. Thyroid dysfunction continues to contribute to the development of poor prognosis of heart failure. What we do see is that there are some mechanisms which cause hypothyroidism, may cause some sort of left ventricular diastolic dysfunction in your patients. So untreated hypothyroidism can lead to increase in inflammatory markers, endothelial dysfunction, or TSH-stimulated apoptotic derived microparticles. And with all those events happening, we can have an event of left ventricular diastolic dysfunction. And so in conclusion, levothyroxine therapy improves systolic and diastolic dysfunction when TSH values are associated with an increased likelihood of heart failure. Hypothyroidism is associated with non-alcoholic fatty liver disease, potentially curable with levothyroxine therapy. We are seeing in the initial stages where there is direct cetogenic effects on the liver, and it can lead to chronic systemic inflammation in your patients. So in the risk of non-alcoholic hepatitis and advanced fibrosis is significantly higher with increased serum TSH levels. Patients with NAFLD benefit from an early evaluation of thyroid function since levothyroxine therapy is effective for reducing the prevalence of fatty liver. Thyroid dysfunction is also highly prevalent in patients with diabetes, increasing the risk of micro and macrovascular complications. We have approximately 1 out of 4 patients with diabetes mellitus who present with overt hypothyroidism or subclinical hypothyroidism. So monitoring of the thyroid function allows early treatment with levothyroxine to prevent metabolic and cardiovascular complications. Thyroid dysfunction is also associated with osteoporosis and a higher risk of bone fractures. Untreated hypothyroidism is the most important risk factor for the development of osteoporosis in premenopausal women and for increased risk of fracture, evident up to 8 years before diagnosis. The treatment for hypothyroidism normalizes bone turnover and bone mineral density. So I do want to emphasize that Euthyrox NF meets the strictest international potency specification adopted for levothyroxine sodium products. Many regulatory agencies have adopted stricter potency specifications for T4 products, narrowing them from 90 to 100%, 110% to 95.0 to 105%. Euthyrox NF meets the 95 to 105% potency specification over its full shelf life. The stricter specifications met by Euthyrox NF can help minimize the risk of adverse clinical outcomes associated with suboptimal thyroid hormone levels. Some important considerations: Euthyrox NF will have a package change as well as a reformulation of its excipients. What we have done is added mannitol and citric acid to our formulation. The way in which Euthyrox is taken and supervised remains the same. The reformulated tablets offer an improved stability of the active ingredient throughout the medication's shelf life and does not contain lactose, benefiting lactose intolerant patients. So I do want to emphasize that lactose has been removed from our Euthyrox NF formulation, where mannitol and citric acid were added. Euthyrox NF offers stability and consistent quality throughout its shelf life, allowing its active principle to maintain a consistent level of quality. So what we see here is that it still meets the stricter potency specification over its full shelf life and provides patients with accurate and consistent dosing in the long term. The active ingredient, levothyroxine sodium, is sensitive to heat, moisture, and oxidation. Euthyrox NF does not contain lactose monohydrate. So some benefits of the accurate T4 dosing: you can accurately and quickly adjust treatment to each patient's needs. You can help patients to quickly achieve and maintain their therapeutic goals, optimizing their long-term safety profile, and there is improved control of hypothyroidism with a positive economic impact on healthcare systems. So what I am currently showing you is a treatment algorithm for hypothyroidism, where we start at the TSH levels for your patients, where they have a low TSH, where they have a TSH high of greater than 10 milli international unit moles. If they're pregnant, where they're subclinical, we are looking at the initiation of treatment of levothyroxine, which starts at 12.5 to 25 micrograms per day, where you have control within 6 to 8 weeks. If not, you do continue to repeat the TSH to ensure that you're achieving therapeutic goals with your patients. So I hope that this slide is a very good informative slide that you can be able to have in your practice when you come across your patients where you need to treat for hypothyroidism. Or new colors for our Euthyrox NF. So many of you may be familiar with our purple scale. Now we have our new formulations that's moved over to more pink, and there are other colors that indicate the strength that we have available. So we do start at 25 micrograms. We go up to 200 micrograms with each dose increases by 25. And I do want to also highlight that we have 88 micrograms available as well as 112 micrograms. This is our new image that we have currently available in the pharmacies. So you should be more familiar with our older presentation, as I had mentioned, with the grades of purple. Now it is the grades of pink, along with the color of the strength. So your patients should be more able to identify what strength of medication that they're on. And we have a newer blister pack where we want to ensure that heat the tablet is not, the integrity of the tablet is not affected by any external factors. So Euthyrox NF optimizes the management of hypothyroidism in the long term. Due to stricter international potency specifications, Euthyrox NF offers consistent and accurate T4 dosing. It's available in a wide range of strengths, and it enables patients to receive dose adjustments according to their medical needs. Euthyrox NF offers a stable product throughout its shelf life, and Merck has been leading the market for many years, and we are proud to say that over 45 million patients are benefiting from Euthyrox NF in more than 100 countries. So So again, I do want to emphasize our Euthyrox NF that we have available. We have all 10 strengths available, starting at 25 micrograms, going up to 200 micrograms. Each dose increases in increments of 25. And please remember that we do have 88 and 112 micrograms available in the pharmacies island-wide. Thank you very much for listening to this presentation.
Yes, and we thank you very much, Ms. Kimberly Skyers from Merck, the Merck representative. And thank you for sharing the use of your product in the treatment of a number of disorders, including fatty liver and osteoporosis, as well as the hypothyroidism. So it was good hearing from you, Kimberly. And we're moving on now to our next speaker. And we're going to have with us Dr. Leo Alexis. Dr. Leo Alexi Walker, and he's going to be joining us for the first time. He is a consultant obstetrician and gynecologist and a specialist in maternal fetal medicine. Dr. Leo Walker is a consultant obstetrician and gynecologist and fellowship trained maternal fetal medicine specialist, a graduate of University of the West Indies from the MBBS through his DM in Obs and Gynae. He completed his subspecialty training in MFM and is part of a small cadre providing advanced care for high-risk pregnancies in Jamaica. Dr. Walker's practice covers prenatal diagnosis, complex antenatal care, and multidisciplinary management of maternal and fetal complications. He's associated with the specialist team at Victoria Jubilee Hospital and has participated in utero fetal transfusions for severe fetal anemia. And this reflects Jamaica's growing capacity for advanced fetal therapy. We can see more of our babies saved. In addition to his clinical work, Dr. Walker is an active medical educator, teaching foundations of obstetrics and gynecology and leading exam review sessions for junior doctors. His public engagements includes media features on gestational diabetes, endometriosis, and patient-centered decision-making in childbirth. He also has a private clinic or two in Kingston, which he can share the address and location with us later. He will speak with us this morning on gestational diabetes and reproductive endocrinology. So it is just for me to welcome you, Dr. Walker. Please come, your time.
Hi, good morning, everyone. I am Dr. Leo Walker, and I like to thank everyone for inviting me to the Women's Health Webinar 2025. This morning we'll just be doing a brief presentation on gestational diabetes as well as reproductive endocrinology and seeking to establish some sort of an integral link between the two. No, just briefly, gestational diabetes mellitus is defined as glucose intolerance first recognized in pregnancy. It affects approximately 10 to 15% of pregnancies worldwide, and that number has been increasing. The complex endocrine changes that occur as a result of gestational diabetes not only increases pregnancy morbidity, but also exposes women to significant postpartum pathologies. Now, what we will seek to highlight is the critical overlap between gestational diabetes mellitus and reproductive endocrinology. Now, as mentioned previously, the global prevalence of gestational diabetes has been steadily increasing. This is due primarily to the epidemic of both obesity, but also advanced maternal age. We have long recognized that Many women are delaying childbearing desires for pursuit of career, higher education. As a result, we have a growing population of pregnant patients over the age of 35. As a result, there's also an increase in pregnancy morbidities, such as diabetes, hypertension, so on and so forth. Now, there exists higher rates of gestational diabetes in South Asian, Hispanic, and of course, all populations, individuals of Afro-Caribbean descent, with 90% of cases of diabetes in pregnancy being attributed to gestational diabetes. And of course, this in and of itself contributes significantly to maternal and neonatal morbidity, and on rare occasion, mortality. In terms of the pathophysiology, pregnancy is a state of progressive insulin resistance, occasionally referred to as a diabetogenic state. Placental hormones such as human placental lactogen, progesterone, cortisol, prolactin, as well as growth hormone, all increase insulin resistance in an effort to increase the available glucose for transfer to the developing fetus. Now, as a countermeasure, pancreatic beta cells undergo both hyperplasia and hypertrophy to increase insulin secretion. However, beta cell dysfunction and inadequate insulin secretion leads to maternal hyperglycemia. Consequently, there's an excess glucose exposure to the fetus, a resultant fetal hyperinsulinemia, which promotes adipose deposition, organ growth, and protein synthesis. And this is simply because insulin in utero functions much like insulin growth factor 1. Now, in terms of risk factors, these are well known, but to name a few, it's maternal age greater than 35 years, obesity, a family history of type 2 diabetes, a previous history of gestational diabetes, and macrosomic infant or stillbirth, polycystic ovarian syndrome, as well as infertility treatments, namely in vitro fertilization, as well as any one of those high-risk ethnic groups which were mentioned previously. Screening and diagnosis, again, well known. We have the universal screening test or the O'Sullivan's test, which is a 50-gram glucose solution. It's usually done at around 24 to 28 weeks gestation. And of course, once screen positive, the patients will undergo the oral glucose tolerance test, which is now a 75-gram glucose solution using the International Association of Diabetes in Pregnancy Study Group criteria, which was developed by the Hyperglycemic and Adverse Pregnancy Outcomes, or HAPO trial. Early screening is often recommended in high-risk women, so in women who would have fulfilled those high-risk criteria, we usually recommend doing a screening at booking and then repeating at 24 to 28 weeks if that booking screening is negative. The glycosylated hemoglobin, or the HbA1c, is not a reliable screening or diagnostic tool for gestational diabetes in pregnancy. However, of course, for those women with pre-gestational diabetes, it becomes crucial in terms of identifying those women who are now at risk of developing some of the pregnancy morbidities and mortalities associated with diabetes. Referring specifically to some of these first trimester risk, such as fetal aneuploidies or fetal congenital abnormalities, particularly cardiac or structural cardiac abnormalities, but also some of the macro and microvascular complications later on, so retinopathy, nephropathy, and so on. In terms of lifestyle, of course, all pregnant patients, once they're diagnosed with gestational diabetes, should undergo some degree of lifestyle modification. This usually involves referral to a dietitian or a nutritionist to limit the amount of simple sugar intake. So we often talk about a balanced diet, carbohydrate restriction, but more so focusing on the intake of complex carbohydrates as opposed to simple carbohydrates. Of course, moderate exercise is key, as that increases insulin sensitivity, increases glucose uptake. And we usually ask patients to focus on upper body exercise, simply because we don't want them doing too much high intensity exercises because of the risk of falls. If possible, we advise pool exercises, pool aerobics, and swimming. And a significant proportion of these patients will show pretty good improvement in terms of glycemic control with just lifestyle modification. Weight management during pregnancy. And to be specific, when we speak of weight management, we have to be clear that we're speaking specifically to reduce the weight gain as opposed to weight loss. Naturally, we won't advocate for weight loss during pregnancy because now that exposes to some in utero risk or risk to the fetus. What we speak instead is to reducing the amount of weight gains. So, for example, an individual of a normal BMI, we anticipate around 25 to 35 pounds weight gain during the pregnancy, and that's completely normal. However, for those individuals who are overweight, class 1, 2, or 3 obese, will advocate for reduced weight gain. So instead of 25 to 35 pounds, we speak to individuals either gaining 15 to 20, 10 to 15, or 10 pounds, depending on if they're class 1, 2, or 3 obese, respectively. Patient education, again, a more educated patient is often a more compliant patient. As well as education on self glucose monitoring and advising them what the target reading should be. And we'll get into that in a little bit. With respect to pharmacological intervention, insulin is often seen as the gold standard, as it allows for very tight and precise glycemic control, which is what we need, particularly as we approach the third trimester and that intrapartum period. Metformin has widely been used, and its use was almost stumbled upon in that it was used in the management of individuals with polycystic ovarian syndrome. And a large proportion of these patients would have ended up getting pregnant whilst on the metformin. And it was then that we discovered that metformin is completely safe during pregnancy and can be used in the management of gestational diabetes. Of course, glyburide is another oral option. But whichever option we are using, the treatment goals are for patients to sustain a fasting around 95 milligrams per deciliter or 5.6 millimoles and a postprandial 2 hour around 140 milligrams per deciliter or 7.8 millimoles. In terms of some of the fetal or neonatal complications, again, probably the most well-known one, fetal macrosomia, birth weight greater than 4 kilograms, shoulder dystocia, or type of birth trauma, which could range from cephalohematomas, bone fractures, neonatal hypoglycemia. As a result of following delivery, there's this massive hyperinsulinemia, which leads to a significant neonatal hypoglycemia, respiratory distress, polycythemia, and of course, at the most extreme ends, stillbirth and neonatal mortality. However, it's important to recognize that it doesn't just stop there. There are risks that can persist to early childhood. So increased risk of childhood obesity, impaired glucose tolerance, as well as early development of type 2 diabetes. In terms of some of the maternal complications, gestational diabetes also increases the risk of some of those hypertensive disorders in pregnancy. So we're talking about gestational hypertension, preeclampsia, eclampsia. Polyhydramnios increases urinary section rates, as well as, again, long-term risk of type 2 diabetes, metabolic syndrome, cardiovascular disease, and possible subfertility. So this kind of allows us to flow nicely into the reproductive endocrinology component. Now, even after delivery, many women retain an underlying degree of chronic insulin resistance, and this state drives hyperinsulinemia, which disrupts ovarian endocrine signaling and reproductive function. Hyperinsulinemia stimulates the ovarian theca cells to produce excess androgens. The insulin also suppresses sex hormone binding globulin in the liver. Therefore, there is less sex hormone binding globulin to bind to the sex hormones, and therefore you have increased free testosterone. These are testosterones which are now able to exert their effects because they're free and unbound. The result is a polycystic ovarian syndrome-like hormonal environment where there is disruptive folliculogenesis, anovulation or oligo-ovulation, and a subsequent irregular menstrual cycle, and of course impaired fertility as a result of irregular and infrequent ovulation. Now, the HBO axis is also disrupted as a result of this insulin resistance and hyperandrogenism because there's an alteration, as we alluded to, in the LH to FSH ratio. Elevated luteinizing hormone drives androgen production, while FSH, or follicle-stimulating hormone, is relatively suppressed, therefore impairing dominant follicle maturation. Without a dominant follicle, there will be no ovulation. Now, this leads to chronic anovulation, which is one of the hallmarks of subfertility. It also has effects on the endometrium. So beyond the aspect of ovulation, there's effects on endometrial receptivity. Chronic hyperinsulinemia and inflammation causes endometrial dysfunction. There's impaired endometrial receptivity due to a dysregulated HOXA10 expression, that's the homeobox10 expression, altered progesterone signaling, and reduced implantation potential. So it's affecting fertility on several fronts, not just ovulation, but also implantation, which can then increase the risk of subfertility, as well as miscarriages. Women with prior gestational diabetes are also at an increased risk of developing polycystic ovarian syndrome through the shared insulin resistance and hyperandrogenism. As you may have picked up, the mechanisms for the two are quite similar. Type 2 diabetes, of course, women with gestational diabetes at a 50% risk of developing type 2 diabetes within 10 years, particularly with those with an increased abdominal circumference. Metabolic syndrome, which refers to the combination of obesity, dyslipidemia, and hypertension. All of these things are increasing in individuals with gestational diabetes, particularly those individuals who fail to have sufficient follow-up in the postpartum period to determine if there is resolution of gestational diabetes or that impaired insulin or the insulin resistance. Now, each of these conditions, PCOS, type 2 diabetes, metabolic syndrome, independently worsens fertility outcomes. So one could only imagine what a combination of these things will do, or how it will impact one's fertility. Some studies also suggest that gestational diabetes may induce epigenetic modifications in maternal tissues, affecting hormonal regulation. These long-term molecular changes may contribute to ovarian aging, poor ovarian reserve, and subsequently a reduced anti-Mullerian hormone level, therefore reducing or diminishing the fertility potential later on in life. So what about prevention strategies? Well, prevention strategies won't come as any surprise. The most important thing, of course, and which is often a step which we tend to miss in our management of patients, not just for gestational diabetes, what we're speaking about today, but a whole host of known pregnancy morbidities, is preconception, counseling, and weight optimization. This is the most important or the best tool in preventing gestational diabetes. Of course, early lifestyle modification, so healthy diet, exercise, and these are the basics, but tried, tested, and we know them to be useful. Regular physical activity before and during pregnancy. Of course, how much physical activity a woman can undergo during pregnancy will vary significantly from one individual to the next. But what we do recognize is being sedentary during pregnancy does increase the risk of these pregnancy morbidities. So we often advise patients to try and remain as active as possible. And of course, identifying and managing polycystic ovarian syndrome and insulin resistance early. So in conclusion, gestational diabetes is a major intersection of obstetrics and endocrinology. Early detection and management are key. Lifestyle modification plus or minus pharmacological intervention improves outcomes. Lifelong follow-up is needed for both the mother and the child to reduce some of those long-term complications which are often unnoticed or would go untreated. Thank you all for listening. I know the presentation was brief, but I think short and sweet is an accurate description. Thank you.
We thank you, Dr. Walker, for this presentation today. So very comprehensive and detailed. And this conversation we're having on gestational diabetes and reproductive endocrinology, there is so much more even to be said. And we're hoping that you will share with us a bit more in detail on PCOS and its place in this disorder. So many of us, of family physicians, really come across so much PCOS in our practice. So we want to hear a little bit more about that in our Q&A, which is coming up. You will have a little more time too, as due to that we have an extra length of time for this purpose with Dr. Channel's absence. We just want to thank you so much. These delays in pregnancy for these youngsters these days, waiting till they're in their 30s and mid-30s, certainly are creating problems, gynecological obstetric problems that mean that there has to be a whole new way of us, family physicians, looking at these older pregnant ladies in relation to the chronic diseases, which increases insulin resistance, and this what's doing to the baby, the increased glucose exposure. So this is also new. It's been around for a long time, but we need to actually acutely recognize what is happening and how we have to look at the management of pregnancy in our practices in a slightly different way. So lifestyle modifications, reduction in weight gain, proper management of the chronic disorders, and a lifelong treatment, lifelong changes in the way we eat and exercise. I want to thank you again, Dr. Walker, and we're now going to invite our gold sponsor, Merck, to come in for their second presentation this morning, and with the second speaker. So we want to go ahead.
Good morning again. Your speaker is Kimberly.
Okay then, right. Go ahead.
Yes, okay. So let me go ahead and share my screen. So today we are focusing on Act Today, Prevent Tomorrow. Sorry. Glucophage XR has more than 60 years of clinical experience. We started in 1922 with the discovery of metformin as an anti-diabetic agent in France, up to in 2008 being approved as first-line therapy for the treatment of diabetes, type 2 diabetes. Every minute counts in the treatment of type 2 diabetes. I do want to focus today a bit on our pre-diabetes website. It's www.prediabetes.la, and what this website does, it provides a few questions to you or your patients to assess their risk of developing diabetes. So this is the landing page that we are looking at. It speaks about, do you know your risk of developing diabetes? Where it also tells us that at least 1 out of 3 adults older than 20 years of age have prediabetes, or 9 out of 10 people with prediabetes will have it and not know that they do have it. So Merck is providing solutions for patients from prediabetes to advanced stages of the disease. We have glucophage and glucophage XR for the treatment of prediabetes, glucophage XR, and glucovance for the continuation treatment of diabetes from monotherapy into combination therapy. Some for monitoring patient parameters, initial visit, blood pressure is taken every visit. You monitor your patient's HbA1c, the lipid profile, electrolyte management for every 3 months. The HbA1c tested every 3 months after a change of medication, or every 6 months, of course, depending on your practice, depending on your patients. Again, I do want to emphasize our product portfolio. Pre-diabetes, the focus is your patients who present to you with 5.5% to 6.5% of HbA1c, and the product geared towards that diagnosis is Glucophage XR. Your HbA1c levels of 6.6 to 7.5 XR and greater than 7.5 is our combination metformin with glibenclamide, Glucovance. Again, 1 out of every 3 adults over 20 years of age has prediabetes. The diagnostic criteria for prediabetes are the fasting glucose, which is 100 to 125 milligrams per DL, or the HbA1c of 5.7 to 6.4. Metformin and lifestyle changes delay the development of type 2 diabetes by 31%. So here we have the original metformin. Glucophage is our original metformin. We are the innovator for metformin. We still have our original tablet line available in the market. We have 500 milligrams, 850 milligrams, and 1000 milligrams in our plain glucophage packages. For our Glucophage XR, or extended release option, which is our once-a-day tablet, it is 500 milligrams, 750 milligrams, as well as 1000 milligrams available. So in our first-line treatment for type 2 diabetes, it is a step-up dosing regimen, because you do want to maximize the dose of metformin. You want to increase the dose of metformin to the maximum tolerated dose for your patient. Usually is between 1500 to 2000 milligrams per day for your patient. The current treatment guidelines drug therapy in the treatment of type 2 diabetes mellitus. So we're starting off with a low dose, not experiencing too much of the adverse effects that may happen with the ingestion of metformin. However, with the use of our metformin or Glucophage XR, that GI discomfort is significantly reduced. So start with low dose metformin. You have up titration according to the patient needs, and you of course, the aim is to reach the glycemic targets and to reach the maximum recommended dose for your patients. If the HbA1c target is not achieved after 3 months in your diabetic patients, you can consider other agents, as well as Glucovance, which is our combination metformin with glibenclamide. And we do have 3 strengths available. We have 500 milligrams of the metformin with 2.5 milligrams of glibenclamide, 500 milligrams metformin with 5 milligrams glibenclamide, and 1 gram of metformin with 5 milligrams of glibenclamide. And the metformin that is used in the Glucovance formulation is our Glucophage XR. So this makes it a true once-a-day tablet for your patients in the treatment, management, and control of diabetes. An emphasis on our product portfolio for diabetes and prediabetes, Glucophage XR and Glucovance, we have available in the pharmacies. I do want to inform you that our Glucophage tablets, we know they were some huge big tablets. We now have a formulation where our tablets are smaller, so they're more tolerated and tolerable for your patient. Formulation, same, the gel shield diffusion technology, which allows the tablet to slowly disintegrate over 24 hours instead of dumping the metformin into the system, still applicable to our new tablets. So just to inform you that instead of these huge tablets that may have been a deterrent for your patients to be compliant in taking their medications, with a smaller tablet, they'll be able to hopefully be more inclined to be controlled and take their medications. Okay. Thank you kindly again for listening to this presentation.
And we thank you, Kimberly, for coming on board again with the Merck flag medication, the glucophage XR, and letting us know how to use it and why we should use it in the treatment of type 2 diabetes mellitus, and also its new formulation and the fact that it's more attractively sized. So thank you again from Merck, who is our gold sponsor today. And we'd like to move on to our Q&A. And I see that Dr. Minot has a question. Could you answer that for him, Sam?
Oh, hi. Doc, what link is being used for persons to enter the webinar? They have to register. I'll speak to you about that in a few minutes. But short, Dr. Brown, back to the Q&A.
Okay, right. So we are going to have an interactive Q&A here. I know that Professor Toller Reed has already done some answers, but we're going to ask him to talk about it because we want to make sure that everybody is hearing and that people can use this Q&A to ask other questions that might interest them, or we have the time. So let us use it in a good way to educate ourselves. So Prof, we had a first question from Dr. Alert, one of our senior executive members of the Caribbean College of Family Physicians regional body, who asked the question, should waist circumference be included or replace the BMI as a screening tool for primary care physicians? Can you go ahead and tell us your thoughts?
Right. So I think they can be used interchangeably. I think the key is really what is most easily accessible to you. There's a very good correlation between the waist circumference and the body mass index. So most persons who have a high body mass index will also have a high waist circumference. But because there's an interest, particularly for cardiovascular outcomes on the central adiposity, the waist circumference may be more directly related to those outcomes. There are a couple other issues as well because the waist circumference has to be measured properly, and sometimes there are challenges with a good technique in terms of where people are measuring and getting that tape measure straight and not lined up or bumped somewhere around the waist. So those are a couple of challenges. So it is a little easier though because you only need one piece of equipment. So you just need your good non-stretchable tape measure. Whereas for the body mass index, you need to make sure you have a stadiometer and a scale. And a lot of times, people may not have access to a good stadiometer, so no height measurements are made, even though they have the scale. So it really depends on what you have available, but I don't think that one need replace the other. If you can do both, that's fine. If you have access to one, that's fine.
Prof, sometimes I wonder about using the tape measure because with a lot of these gentlemen in particular, I find it very difficult to know where is the waist, the belly sometimes with the umbilicus gone low down and there's
Yes.
a big thing there and you're not quite sure how to do that measurement. What do you suggest?
Yeah, so that's a challenge. So the waist circumference actually needs a bit of training. So when we do waist circumference in our surveys, it takes a few tries to make sure that we're getting consistent results. And in fact, for the larger study that we did, in the end, we just trained a core group that we knew could do the measurements well. The big challenge is really around the lining up of the tape measure and then finding the landmarks. So we will use the ASIS, so the person usually has to try and identify that spot, usually by touching, and then the lower part of the rib, and we do the waist circumference measure around that midpoint. So that is where the challenge is, and you have to make sure that the tape measure is not is not leaning up or down, like you start low on one side and it's going up. So you're getting a diagonal instead of a straight measure. So sometimes that's a little bit more challenging and time consuming. But if that is what you have, and I think the idea of the tape measure is, it's a lot more portable in terms of moving around. And in some ways, so people can relate to it, even though what people talk about as their waist size and so on may not necessarily be an exact measure of the waist circumference. It can give them an idea of where they're supposed to be or how far they are from where they're supposed to be.
Yes, well, I'm thinking that if possible, we should also try to do the BMI because we can't lose.
Yes,
And these male bellies, I call it
Mhm.
bellies, can be such a difficult thing. I think we need to train. Perhaps
That
we need
is,
to have a little training session
yes.
so that we can with a person or a faceless person or something for us to actually know. That's a very good idea, I think, to show us how to do this thing properly. So that's an idea, Prof, if you can. In the meantime, while I move on to question 2, I'm going to ask people to see if there are any questions that they want to put in the Q&A for Dr. Walker, who finished his session on this whole idea of reproductive endocrinology and gestational diabetes. Now, we had a person, is it Tian Palmer McCoy, just thanking you for your excellent presentation, Prof. And then we have another name, Radharani Dodd Reddy, asking, is this from Trinidad? Asking what is the cardiovascular risk for a patient with normal weight, with truncal adiposity and elevated total cholesterol and triglycerides. So that's a mouthful, but easy for you. So go ahead,
I
Prof.
don't know that. Well, I guess what this is the whole cardiovascular, kidney, metabolic health issue is really around pulling all the risk factors together and not treating them as sort of lone risk factors. Usually what we use for risk stratification is in that patient. So in other words, that patient who is obese would already be past stage 0, so they're not at the ideal weight. There is some evidence of metabolic dysfunction, so the cholesterol is high. I don't have the the triglycerides are high, as was said. So there are a couple of other things that we can do to risk stratify with the blood sugars to see where they are, if they have prediabetes based on that, and they may be at maybe a stage 2. Okay, if you can remind me of the question, how the cardiovascular risk. There are a couple of tools that we use. I tend to use the ACC risk score calculator. That one is usually one of the things that helps us to guide whether we should begin cholesterol lowering therapy. But the good thing about that risk score calculator is that it also addresses in a direct way how we should manage other risk factors. So if you've used that app, then you can put in the data that you have for the patient. It's not designed for Caribbean populations. It's really based on a number of US cohorts where they've looked at all these risk factors and how they relate to the risk of a cardiovascular event or early death. But it does give you a good sort of estimate of their risk. And then it gives you another measure, which is what their risk score could change by if the risk factors were managed. So you might do it and it says this person's risk of a cardiovascular event in the next 10 years is 20%, but with optimization of blood pressure, cholesterol, etc., their risk could go down to 5%. And it's very explicit in terms of saying, okay, add a high intensity statin, get the blood pressure down. If you flag things like smoking, encourage smoking cessation. So it gives a lot more recommendations. And I like it too because I can share it with the patient. So when we're having our discussions around, should I take this tablet and what can I do? You can say, well, here is the score. Here's what we could expect if you were doing better in these areas. And then you can help me decide what you want to work on. So I often share the score with them. That is the way I think I would use to sort of assess it. What C CKM is looking at as well is that sometimes with some conditions we may not be anticipating whether there's any underlying heart disease or kidney disease, and then it's encouraging us to also include that as part of our evaluation. And that may be something else that will move you from a point of saying, okay, let me just manage the risk factors, to being, okay, we need to get serious because this is a high-risk person we're dealing with, and we need to be more aggressive, deliberately adding specific medications to reduce their risk of a cardiac event.
Quite global. The management is quite the whole risk assessment thing is actually growing. Maybe more will be added to it to get a tighter, an even tighter picture of how we're going to use this. But it's exciting, and I think more of us need to depend more on these tools. Many of us, the older ones in particular, do not go to these tools, still go by their knowledge of their patients and their interactions with the patients and what they record and what they're getting each time. Am I improving or not? But they need to get this sort of a risk, a score, a real life score that's not based on what you think, but it's based on the reality of what is going on. So I guess we need to do more of that as well, encourage our membership to get involved in using these tools. What can you tell us, Prof, about this the Jamaica Health and Lifestyle Survey that's coming? You're part of it.
Yes, I'm part of it. So it's evolving. I think we've more or less decided on what we're going to be collecting. I think there's a couple new things that people are interested in, but as usual, it's going to be a national survey around the island. Sampling is usually done by electoral divisions. Just like what we had recently.
Like an
Yes.
election?
Well, as the best way we can find a representative sample. Anybody over 15 and up is eligible. I think the last survey was the first one where we took all ages before we traditionally stopped at 70, but realized that it's important to look at health as our population is aging and not just at the young people. And it's again going to have the focus on the non-communicable diseases and the risk factors for non-communicable diseases. I know some of the things that they have a special interest in, and we'll see how it works out based on the budget that's available for this study. There's a lot of interest in doing some kidney assessments again, to collect a little bit more on that. There's a lot more interest in some of the social determinants of health, particularly things like food insecurity, which we don't talk about much, but which may impact our diet. I know the previous survey, we started looking at things like pregnancy experiences, because especially for women, you see the numbers where we have just this, the figures for Jamaica and the Caribbean are very different from what you see in most developed countries, because usually it's the men that are obese, but in Jamaica it's the women that are more obese, and that's a different paradigm. And so it kind of throws a lot of the things that we use to estimate risk around, because we often assume that women are smaller, they tend to have, lower blood pressure in some cases, or a more favorable cholesterol profile, because the hormones, the estrogen and so on, is protective in those early stages. But then when we have a situation where there's just a lot of obesity, we can't tell which way the needle is going to flip. So that obesity now increases the risk of diabetes. The diabetes removes all your protective premenopausal benefits, and then you're not sure what you're going to end up with at the end of the day. So I think it's kind of interesting for us to begin to figure it out. So we have been looking at a couple of things, not just gestational diabetes. We've been looking at hypertension in pregnancy as well, because that's another marker. And then the pattern of obesity, you have to kind of think around what they call this intergenerational cycle, because the early obesity is one of the things that results in a higher risk of diabetes in pregnancy. So if by teenage, so you're talking about women waiting and delaying until they get older. I think if they delay when they get older, pregnancy till they get old, it's not a problem as long as their health is maintained. But what we are finding is that because they are unhealthy coming into pregnancies from their early, and you don't have to, when you look at the numbers, these are people in their 20s and 30s who are the primary persons having children still, and who are coming into the pregnancy, unhealthy state. So then you're ending up now with a lot of maternal deaths, primarily due to hypertension, diabetes, and not the traditional things like, the postpartum hemorrhage and those kinds of things. And then it has implications for the children, because what we have shown, or has been shown in other populations, is that when these pregnancies are affected by those kinds of conditions, the children are coming out of the pregnancy with a higher predisposition to these conditions. So you'll see over time a lowering of the age at which a lot of the chronic diseases are occurring. So the children are more likely to be obese in a mother who has had gestational diabetes. That obese child is coming into a pregnancy overweight and then more likely to develop gestational diabetes. Then the baby of that child is now growing up in this environment and coming out with a higher predisposition. And if the environment in which we are having everybody develop, in terms of what is available in the schools or activity or transportation systems, all of those things that may lead to poor dietary choices, sedentary behaviors, are just going to compound what might be a sort of pathophysiological effect. So when we kind of look at all of these things, we're kind of saying, well, we can't just be focused on one thing. We have to kind of look at everything, and then we can't divorce the health issues from economic and social issues, which we knew for a long time, but it's just becoming a lot more. You think about a lot of things and you see, you're watching economy, okay, that's going to affect your dietary diversity. You're watching, trade practices and industry
One health.
practices. All of
One,
these things are coming together.
one health.
Development, pollution, your transportation policies, all of these things, school curricula, how much time the students get to exercise, how much time is spent on different things, the quality of life, how well they're building relationships with each other, with, a lot more of the, interaction by computer as opposed to in person. All of these things are coming back to
And
attack
of course,
us.
what we're seeing is how interrelational we are. We are not just physicians isolated.
Yes.
It's the whole community
Mhm.
and how the whole community is interacting with its members, what we're promoting through not just the medical fraternity, but also the health, the
Yeah.
agricultural space,
Yes.
and it all is one. So I'm
Mhm.
also wondering if Dr. Walker wants to make a comment here on this topic. I'd invite Dr. Walker to make some comments on this whole area. Is he available? Sam, we have Dr. Walker with us, or has he stepped away?
Dr. Walker actually sent a recording, so he's not here.
Oh, he's not actually here
Okay.
with us
Yes.
right now. Okay.
No, no.
So I can't ask him to answer any questions on
I
people.
can try.
Unfortunately.
Go
I
ahead.
can
Go
try,
ahead.
but I don't know
Go
how good
ahead.
I'm going to be.
Go ahead.
Yeah. I did see one of the questions on the gestation there's a question that I saw on metformin. I don't know if it was answered. and use in gestational diabetes. I think the key things, so gestational diabetes for us as endocrinologists is really a emergency. So if you call me and tell me that you have a patient that has gestational diabetes, even if the schedule is full, I will have to see that patient the next time I'm in office, even if I'm dropping down, because the process is what happens in that period is very critical. We really can't waste time. And so we need to move the patient to a safe zone, particularly when we want to think about the pregnancy. So there are a number of strategies that you can have. I mean, Dr. Walker spoke about ways in which you can screen. And I know officially that there's supposed to be universal screening. I think that is what people are considering now. I think maybe for our population, it would be a good thing because we have so much obesity. So if we don't screen and we wait and say, let us risk stratify and say, okay, you're over 35, that is maybe good 20 years ago. I don't know necessarily if we can be, going with those metrics anymore, because the whole pattern of health and what people are coming into pregnancies with is very different. So I wouldn't disagree with a universal screening. And then once you detect it, you do your other tests to confirm the diagnosis. And then at that point is really a lot of the interventions based on what the blood sugars are. So as he mentioned, the first thing is usually the lifestyle changes. So we work with the eating and activity, particularly beginning to help them to reduce carbohydrate intake, adjust the times or the amounts. I think because a lot of times for women, it's a teachable moment. And I must say that a lot of times this is maybe the one opportunity that you have to do some meaningful impact, because when they realize that the child is at risk and other things, even outside of their own risk, then they are more willing to take on some things. So people are sedentary, they'll see them trying to bicycle, they'll see them trying to walk, they will follow the meal plan a little bit more carefully. And then it's a time we usually do a lot of intensive monitoring. So we ask them to get their glucometers and do checks up to 7 times a day, because we need to know if the blood sugars are where we want them to be. The options we have are a little different. The orals, the metformin is an option, but a lot of times if the sugars are not where we need them to go, it's insulin. And even though there's a lot of debate about it, the pendulum is swinging. Sometimes they'll say oral, sometimes they'll push insulin, but the key is to get the blood sugar to goal. And a lot of people believe that insulin, even though it's a lot more work, may actually allow less of some of the adverse outcomes, like the size of the fetus maybe a little bit better with the insulin, because you can control it and get them a lot tighter than you might with the orals. But the metformin I've managed with a mix. Metformin may be okay for some, and then they do okay with that. Metformin and a basal insulin may work for some, but if there's risk, then we just go straight to.
Do you find that you can use metformin alone?
Yes, I have a few patients who have been managed with metformin. I think the biggest thing around it is that it's a wake-up call, because that mother is in a high-risk category. And I think that is really what we want to begin to move, because the pregnancy is really just a test. The pregnancy is a test of what your body how your body responds. And I think unlike, men don't have that kind of litmus test where you can know what will happen if something about men. Women can have that, can have that test.
Very high risk for your CKM.
Yes. So once they do that, and then they're having the hypertension in pregnancy, this is somebody you need to watch that blood pressure. They'll have the diabetes. You need to say, okay, the pregnancy is over, but please try and stick to the meal plan, because you're at risk for obesity or, diabetes, etc.
I see Dr. Standard Bolson has her hand up. Can we recognize Dr. Standard Bolson, please?
Thank you very much, Dr. Brown Morgan. Prof, you mentioned in the diabetic patient, you might want them to do blood sugars as often as 7 times a day. What is the status with us getting the continuous glucose monitoring instruments or
Yes.
apps in Jamaica.
In Jamaica. Oh boy, I hope somebody from one of the companies is on. So that's not something that we have had access to at all.
Oh boy.
I know the one that I have used quite a bit is the Freestyle Libre, because that was the first one that was accessible without calibration. So the first set of these monitors, you had to have, if you bought it, you had to have the sensor, and you had to have a glucometer that was linked to the sensor, because the sensor had to be recalibrated based on real-time blood sugar measurements. But then when they started now with the newer ones don't require that calibration. So you previously had to do finger prick at least twice a day, and then it would link to your CGM, and the CGM would know if it's accurate and recalibrate based on that. But nowadays, you don't need any glucometer. So once you have a CGM on, you're fine. The problem is that we are not accessing it here in Jamaica. I think there are a couple of islands where once you're actually even trying to use the software, you're going to be blocked. Um, so once it detects that you're not in the US or in Canada or in one of the markets that they have approved for distribution of these items, you can't download the software. You have to be using, I can't say it on the thing how we can do it,
Yes.
but you know, there are
Yes.
ways to go. You can go to Miami, literally or virtually, and download things. But we don't actually see, I don't know what the idea is. I mean,
It's one of
whether
the things I think we need to lobby for, advocate for, because I think it would make a big difference to our self-monitoring of patients.
it could, especially in like situations like that where you require that level of intensity. I think sometimes the market share is what decides on some of these things, because I know a lot of things we're not getting access to when they look at the benefits. In other
Yeah.
words, okay, how many people will be able to pay for it here, and it doesn't make sense. It's a waste. So we can make the money in
Other
America
ways.
or whatever it is. There's no need to think about 3 million when we have 250 million that we can market to. Plus, they're looking at things like whether the insurance is going to cover it. And we already know that there's challenges, even with just our strips, with the insurance coverage that the patients get from their health insurance. So they kind of look at it and say, well, this won't be a profitable market.
Thank you.
Right. Thank you, Dr. Tollery. So there's one question or statement from Dr. Colin Alert, saying that PAHO has produced CardioCal, a risk factor calculator for Latin America and the Caribbean, but few physicians seem to use it. We're just talking about that and promoting it. What do you think of this tool?
Right, yeah. So this is something that is being done. So throughout the region, Jamaica hasn't taken on that program, but the POW has been working to try and reduce cardiovascular events generally. And they have put forward what they call a Hearts in the Americas program, and that focuses a lot on overall cardiovascular risk management. So they have guidelines on hypertension, cholesterol, etc. And one of the things that they have used is an adaptation of a risk score calculator, which has been put out by the WHO, and they actually do region-specific modifications. So it has a number of charts that you can use. And the idea is that rather than have the calculator, or I think now they have an app, so you don't have to go on the old-fashioned thing where you look at the chart, but they will have a number of charts. They have charts for men, women, whether you have diabetes, and then it splits into age groups. So you have that, and you can look at your patient and say, I have a woman, and based on what you have, they've done the charts for whether you have lab data available or whether you don't have lab data available. The idea being that nobody should not be able to have some sort of cardiovascular risk assessment if they don't have access to everything. So in your clinical assessment, you can find out the person's age, you can assess their sex, you can know whether they smoke, you would know whether they have diabetes. You can measure the blood pressure. So even without the cholesterol values, you can risk stratify that person to say you're high risk, low risk, etc. And then that risk stratification forms the first stage for you to say, okay, we need to start getting your blood pressure down. We have been doing the diet thing for the last 3 months and nothing is changing. We need to start you on something because this blood pressure needs to go down. We have been talking about this and that for a long time. We need to add on these things. I know people are, there's a inertia that sometimes takes place with patients, partly because you're switching, so you're in the clinic, you see one doctor this month, you come back and you see another person and they don't remember what the first person was doing. So you keep going like that for a long time without really being proactive and making changes that can change what's happening. Or in our practices, we know the patients and we say, well, we try, and sometimes, say, give me a chance, doc, give me a chance. And you say, okay, and before you know it, it's 2026 and you're still giving them a chance.
Still nowhere. So we really need to document and be more aware of if we're making progress or not.
Yes.
I'd like to thank you so very, very much, Professor Tulloch Reid, for actually giving us a Q&A, which was of CME quality, the back and forth, the detailed information provided to our participants today has certainly given us much guidance in moving forward. So we want to thank you so very much, Prof. And I am giving you a clap.
Thank you.
And it is now my pleasure, distinct pleasure, to invite Dr. Aileen Standard-Golson to come on board as the person who is going to moderate you through the second half of our CME webinar today. So Dr. Standard-Golson, over to you.
Thank you very much, Dr. Brown Morgan. Hard to follow your dynamism and enthusiasm, but we will make our efforts. We've had a very informative first session, and I'm sure that the second session will be equally as informative. Want to move right in to introducing our first speaker, who is Dr. Karen Phillips, who is a consultant endocrinologist and physician serving at Kingston Public Hospital, where she is a former head of medicine. She is an honorary consultant and associate lecturer at the University of the West Indies and the immediate past president of the Association of Consultant Physicians of Jamaica. Dr. Phillips holds a DM in internal medicine, an MSc in diabetes and in endocrinology, MRCP, member of the Royal College of Physicians UK in diabetes and endocrinology, and is a fellow of the Royal College of Physicians of Edinburgh. Clinically, she manages the full spectrum of endocrine disease with additional focus on obesity and cardiovascular risk. Her scholarly work includes peer-reviewed publication on subclinical hypothyroidism in pregnancy, and she contributed to Jamaica's interim guidelines for the clinical management of diabetes out of the Ministry of Health and Wellness Jamaica 2020. A trusted educator and examiner, she is committed to patient-centered, guideline-driven care. Today, we are very happy to have her with us to speak on the topic of obesity and the metabolic syndrome. So Dr. Phillips, over to you.
Thank you very much, Dr. Standard-Golson, for that warm introduction. And it is my distinct pleasure to be presenting on obesity and the metabolic syndrome in this forum today. We do know that there is an interesting interlink between obesity and the metabolic syndrome, and arguably one would say that obesity is in fact the most important contributor to the metabolic syndrome. So I'll just start with two case presentations, which very simple. The first one is they're real patients, a 38-year-old male with no established chronic medical illnesses who really came into hospital, well, because he did a recent executive profile as a part of a routine job medical. And the results of that had revealed abnormal liver function tests. And subsequently, an abdominal ultrasound was ordered, which revealed findings suggestive of a fatty liver. His current BMI is 38 kilograms per meter squared with a waist circumference of 45 inches. And so the question is going to be, sorry, why am I not? Right. So which of the following is not a component of the metabolic syndrome? High blood pressure, fatty liver, waist circumference, low HDL, and high triglyceride levels. And we'll come back to that. The second case is that of a 55-year-old male who presents out of concerns about a 30-pound weight gain over the last 3 months. And I saw this man on Friday in my office. He had done a minor off-beat procedure then. So he currently weighs 360 pounds. His baseline is 330 pounds, but he was happy at that weight. He complains that he really is trying hard and it's not working out. He's consuming large servings of carbs because he works as a construction manager, and that is what he gets on the road. So you ask if he really wants to discuss his weight in this visit, and he says he gives you permission. What do you do next? Do you agree with his decision and proceed to make smart goals? Do you assist him by referring to the dietitian and exercise therapist? Do you assess him by first taking a comprehensive history, advise him on the need for a long-term weight management strategy, or do you assist him by referring him to internet resources on weight loss? So we'll get back to these at the end of the presentation. And so in a nutshell, the metabolic syndrome is really a constellation of medical problems or medical disorders, abdominal obesity, dyslipidemia, elevated blood pressure, and elevated glucose, quite simplistically put. But the diagnosis is actually based on 3 of 5 components. In terms of abdominal obesity, we're talking about men with a waist in excess of 40 inches, women greater than 88 centimeters or 35 inches, hypertriglyceridemia greater than 1.7 millimoles per liter, low HDL cholesterol for men less than 1.036 millimoles per liter, for women less than 1.295 millimoles per liter, elevated blood pressure, which is greater than or equal to 130/85 millimeters of mercury, or the use of antihypertensives, and elevated fasting glucose of greater than 6.1 millimoles per liter. So the metabolic syndrome is associated with a pro-inflammatory pro-thrombotic state. And this is characterized by an elevated CRP, elevated endothelial dysfunction, hyperfibrinogenemia, increased platelet aggregation, and plasminogen activator inhibitor 1, and microalbuminuria. And the associated clinical conditions include, as listed here, insulin resistance and type 2 diabetes, cardiovascular disease, fatty liver, PCOS or polycystic ovarian syndrome, sleep apnea, gallstones, and hyperuricemia. So how does obesity contribute to the metabolic syndrome? So we have to be familiar with the functions of the adipocyte or the adipose tissue. And we frequently think of the adipocyte or, as a storage organ, but it is actually the largest endocrine organ, secreting hormones, leptin, adiponectin, angiotensin 2, IGF-1, activating sex hormones and glucocorticoids. And it plays a very important immune function in producing cytokines and complement proteins. The visceral fat depots release inflammatory adipokines, as listed here, the adipokines, tumor necrosis factor alpha, interleukin-1, interleukin-6. Inflammatory adipokines and free fatty acid form the pathophysiological basis for the comorbid conditions in obesity. And the anti-inflammatory and anti-atherogenic substances, which are also secreted as mentioned before. And just to note that the buttock fat and subcutaneous fat, which we encounter in persons, really performs mostly of a storage function. So there's this very expansive definition of obesity as a chronic relapsing multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue, dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical, and psychosocial consequences. And this is out of the Obstetric Medicine Association. But of course, I think it is more useful to look at the WHO definition from 2000, where they look at obesity as an abnormal or excessive fat distribution that presents a risk factor to health. Of course, just historically, we're coming from far away, 460 BC, when Hippocrates would look at obesity as a surplus of humors, green bile, black bile, blood, and phlegm. So we've come a way distance from then, where we actually have actual structural definitions based on BMI, which we'll discuss in a little bit. And of course, if we're going to talk about obesity, we must think of the historical context, where obesity was recognized as a sign of affluence associated with plenty of food and other luxuries. Published data suggests that obesity can, however, no longer be used or looked at in terms of higher socioeconomic status. And there's data from the National Health and Nutritional Survey from 1971 to 2000 of adults between the ages of 20 and 60 years, which showed an increased prevalence of obesity among low socioeconomic groups. It's moving right along. Right. So when we look at our Jamaican figures, 54% of Jamaicans older than 15 are overweight or obese. So that's 1 in 2 Jamaicans. And the prevalence of obesity in Caribbean children is actually 2 to 3 times higher than in the world. And that is out of a paper by Crack et al. In 2016. The 2017 Global School-Based Student Health Survey also demonstrated an increase from 5.3% to 10.3% in boys, and in girls, an increase from 6.7% to 9.9% since 2010.
Doc, I think you're muted.
I'm sorry. Let me just go back quickly. Right, so basically, looking at this graph, which is looking at the prevalence of overweight over 4 decades, since the 1970s to the 2000s, with a greater increase, of course, in females over males, but a steady increase. And looking at the classification of obesity, we can see that the normal range in terms of BMI, and we'll discuss that in a little bit, of 18.5 to 24.9, overweight being greater than 25 or 25 to 29.9, class 1, 30 to 34.9, class 2, 35 to 39.9, and class 3, greater than or equal to 40 kilograms per meter squared. And if we look at the classification, not only by BMI, but also by waist circumference and associated disease risk, we can see that for classes 1 to 3, there is, in terms of men with lesser waist circumference, less than or equal to 40 for men, less than or equal to 35 for women, that there is an increase to extremely high disease risk, and certainly over 40 for men and over 35 for women, a high to extremely high disease risk for both men and women, respectively. This may not be projecting very well, but this is really just to show the modified King's criteria, which is really an holistic obesity scoring system, looking at airway, looking at body mass index, comorbidities, looking at health, perceived body image. So it's looking at the patient in a holistic context beyond the BMI, and looking at what is normal and looking at risk of disease and established disease as against advanced disease in these persons. And we can see as body mass index moves up, we can see that persons move from just maybe mild snoring to needing CPAP and going to cor pulmonale. For cardiovascular disease risk, again, we can see the risk of heart disease and heart failure for those with established and advanced disease. For diabetes, again, full-blown diabetes for established risk disease, and for those with advanced disease, uncontrolled diabetes. The economic burden of this, which is more significant for those with advanced disease who are likely to be underemployed or unemployed and not very mobile. Functional issues as it relates to persons with advanced disease not being able to move around, being more housebound. And also in terms of sexual dysfunction, this is more extreme with those with advanced disease. And health perceived body image, again, moving from maybe a low mood, quality of life, to severe depression and eating disorders with purging for those with advanced disease. The Edmonton scoring system again looks at the overall health impact of obesity beyond the BMI. And for stage 0, there are no obesity-related issues. Moving on to stage 1, where there's some clinical risk factors. So stage 2, presence of established related comorbidities. Stage 3, end organ damage. And stage 4 with significant end-stage complications. So how do we measure obesity? And these are 4 common measures, and I'll look at each of them. For the body mass index, we do know that the body mass index is the most commonly used measure of adiposity. It is not a perfect measure. We do know that it is convenient, it is easily accessible. You just really need the height and the weight. So it takes into consideration body stature or height and is expressed as weight divided by height in meters squared. We do know that there are some correlations with levels of fatness and adult morbidity and mortality. However, the usefulness tends to decrease in individuals with changing levels of muscle and fat masses. And you can think about your gym buff guy and your chronically ill persons. And also it poorly represents regional fat distribution, and so it doesn't give a good indication of visceral or regional fat, and that is very important. So when we're using the BMI, we need to bear those caveats in mind. On the other hand, the waist circumference is highly correlated with visceral adipose tissue. And interestingly, I mean, in former times, way back in 1996, there were papers out showing that Blacks have more upper body adiposity compared to whites. But later studies have actually gone against that, suggesting that African Americans were shown to have less visceral fat than their non-Black counterparts. But this brought to question the whole issue that Blacks have a greater propensity for metabolic aberrations compared to whites. So why is that so? And there are some who think that this may be due to the overall increased rates of obesity in Blacks versus whites. And of course, there may be other issues, socioeconomic and other considerations as well. The waist-hip ratio is another mark of abdominal obesity, and it has also been shown to have potent associations with cardiovascular disease in some populations, quite independently of BMI, but it does have inherent weaknesses in terms of the influence of pelvic structure, which may vary per population. The weight to height ratio is another straightforward tool to assess central obesity, but its effectiveness is not fully evaluated across all populations and age groups. And definitely more research would need to be done to validate this against direct fat measurements. So we're not using that now. So as of now, we're using body mass index and the waist circumference. All right. So in terms of the fat distribution, it's very important that when we're looking at obesity as a disease, that we understand that there are different shapes, so there's the apple-shaped obesity and the pear-shaped obesity. And the apple-shaped obesity is that one which we are more concerned with, in that it's associated with a metabolic syndrome and the high risk of other health problems. And this really refers to more visceral fat, so it's more belly fat. Can happen in persons who are generally obese and can happen even for slim persons as well. The excess fat around the hips, which is more gynecoid type of fat, those persons who have less visceral fat, this is less commonly associated with metabolic syndrome, may have a lower risk of cardiovascular risk, but it's still very important to know that there are other risk factors and other comorbidities, which, mechanical issues, integumental issues, as we look at. So it's not that we're saying that because you're gynecoid, then you don't need to lose weight. We're just saying that you may be at less risk for the metabolic syndrome. And this is just a pictorial of the pathophysiology of eating and weight regulation, very complicated, but it actually, what I want to emphasize and the take-home message from this pictorial is that ghrelin is a very important hormone in terms of stimulating appetite. Most of the others, cholecystokinin, GLP-1, GIP, PYY, insulin, amylin, and leptin will have a kind of inhibitory effect on appetite. So these are more satiety related, and they both have interplay with the hypothalamus and so affect appetite and energy expenditure. So when we're thinking of the pathophysiology of obesity, we need to bear that in mind. We need to also consider that we're way past the era of energy in, energy out. So we do understand that there are behavioral or lifestyle choices such as diet and exercise and sleep patterns, which are very important in contributing to obesity. But don't forget that there are genetic issues. There are neurologic issues, as I just mentioned before. So the brain's hypothalamus, if any dysregulation can affect appetite and energy expenditure. There are metabolic issues with the hormones I just mentioned and any dysregulation of these. And don't forget, there's the gut microbiome, which is coming into its own in terms of affecting nutrient absorption, inflammation, and energy metabolism. And so very, very important. So when we look at obesity, we definitely need to look beyond just the sedentary lifestyle and poor diet, but also the social determinants, the sleep, hormones, aging, attitudes, genetics, epigenetics, and other medical disorders and drugs. Basically, this is saying the same thing. The underlying causes of note, insulin resistance, sleep apnea, binge eating disorders, hypothyroidism, and we just mentioned the microbiome, etc. So obesity is indeed multifactorial and not just energy in, energy out, just for reinforcement. So there are a number of adiposity-related health conditions, and this is how we're looking at it now. So we are looking at from the brain, there's body image dissatisfaction, decreased sex drive. In the lungs, there's obstructive sleep apnea, hyperventilation syndrome. There's NAFLD or MASLD now, fatty liver. There's GERD, there are kidney stones, renal carcinoma, osteoarthritis, so the mechanical issues I mentioned, integumental issues, stasis pigmentation, skin tags, hematology, we spoke about prothrombotic state, infertility, metabolic syndrome, cardiovascular disease, intracranial hypertension, and the list goes on and on. And people with obesity do have an increased risk of dying from 16 types of cancer. So that's important. So this is the state of the issue with obesity. This is what can happen from it. And, this is what we encounter when we see our patients. And so how does weight loss help in all of this? And we know that weight loss definitely is not just beneficial, to just say, okay, just lose some weight. We do know that there's data to say that if you lose 2.5% of weight, you're going to improve your blood glucose levels, you're going to improve your triglycerides, you're going to improve fertility, PCOS. If you lose 5%, you're going to improve depression and your overall quality of life. You will improve liver fat. You will improve sexual function, incontinence, and LDL. Losing up to 10% can improve sleep apnea, non-alcoholic steatohepatitis, as we said before, and over 10%, 16% reduction in cardiovascular disease and overall mortality. So definitely benefit for losing weight, even 2.5%. So you don't really have to lose a lot to get benefits. So the components of obesity care, therefore, should look at the underlying causes, which we looked at: nutrition, medications. We should be able to do some exercise counseling with our patients and, encourage behavioral change or refer them accordingly to get that done. So there is an approach to the patient with obesity. A patient comes to your office, and this is a very stigmatized area. It's very delicate to deal with a patient suffering from adiposity issues. There are certain terms that you could use which could turn off a patient, by referring to them as fat, so we have to be very, very careful. Although contextually in our culture, some people really, glorify, increased adiposity, and, the fluffy phenomenon is well known and well accepted, or thick. But we do know that, all of these patients, as we said, are at risk of disease. And so the 5 A's approach really came out of studies on smoking, wanting smoking cessation. And this tool was shown to be very, very powerful in terms of, as a psychosocial, psycho-emotional tool. When we ask permission, so a person will present to you, maybe out of concern of weight, or for weight, and, may have been referred, but that doesn't necessarily mean that they want you to manage their weight. And it's very, very interesting because there's a patient who actually came to me maybe a couple of weeks ago, and she was actually referred because the doctor was saying, she needs to lose weight. So the lady came and she said, the doctor said, I need to lose weight. And yeah, I know I'm big, but I don't have a problem with it, So she was not ready. So I was not able to have that conversation with her. So when asked if she wanted to have a discussion around her weight and losing weight, she was not interested because she didn't have a problem with it. So even though she came on that pretext, she really didn't want any management for her weight. So it's very important that we understand that, and we do that before we take a history. We assess the anthropometric measures, BMI, waist circumference, do the investigations, give advice on health risks, benefits of weight reduction and treatment options, agree on realistic goals, behavioral changes, and a treatment plan, and assist in identifying barriers to weight loss and connecting them to appropriate healthcare professionals or arrange regular follow-up. So there is a system and protocol and format in place that we should approach our patients with. So our patients come to us, they want to trust us, they don't want us to stigmatize them. So whatever our own personal biases may be, we need to understand that and approach them from a neutral and compassionate place. So, of course, again, very important, the comprehensive history to include diet, physical activity, behavioral patterns. We must measure height and weight to get the BMI we spoke about and the waist circumference, and screen for obesity-related conditions. The laboratory tests that we're interested in are routine metabolic screening, glucose A1C, lipids, TFTs, liver function tests, uric acid, and chemistry. So what then are the goals for weight loss? We've done all of this and we're with our patients and we're going to talk to them now. So we're going to try to lose weight. We're recommending that patients should be losing at least 10% from their baseline. And based on the other slide I showed where the benefits of weight loss, we can see that at 10%, they're way on in terms of improving a number of risk associations and comorbidities. So we recommend weight loss. So it is recommended that weight loss should be about 1 to 2 pounds per week for a period of 6 months. We're not really trying to get the drastic weight loss. We're trying for a more gradual approach, which is more sustainable. But we know that weight loss is hard. So outside of appetite adaptation, there are issues such as once you start losing weight, you're making more ghrelin. This is a hunger signal. You're going to eat yourself back to baseline. There's decrease in your satiety signals, your leptin, your PYY, CKK, amylin. So your fullness signal decreases. So again, this is going to make you eat some more. So you're going to get right back to baseline. And that is why it is so important that we understand that and understand that the journey is not really over just with losing weight, but really begins when you lose the weight to maintain the weight. So the indications for treatment are BMI greater than or equal to 30 kilograms per meter squared or greater than or equal to 27 kilograms per meter squared with obesity-related complications. For children over the age of 12, phentermine, clopramide, ER, liraglutide, and semaglutide are approved. And of course, all obesity pharmacotherapy is contraindicated in pregnancy. So the pillars of treatment, therefore, are lifestyle, medication, and surgery. And when we look at our goals, we're trying to achieve in terms of lowering our blood pressure beyond 130/85, we're looking at correcting blood lipids, and we're trying to lose at least 10% of our basal weight in 6 to 12 months. And of course, we're trying to incorporate physical activity 30 to 40 minutes per day, 3 to 5 days per week. And how we're going to do that with diet, definitely low-calorie diet, reducing fats, carbohydrates, individualized planned diets are good to create deficits of 500 to 1,000 calories per day. We know that if you lose 2,500 kilocalories, it's about 1 pound, so you can do the math. So the important thing about diet is that it should be affordable, practical, and sustainable. So definitely portion size is important. Reduce the salt if your blood pressure is elevated. Reduce your alcohol. The gentleman who came to me admitted to drinking a lot of alcohol 5 days a week. Increasing whole grain fruits and vegetables according to a Mediterranean type diet, and fish, especially in hypertriglyceridemia. So we're not really proponents of any particular diet for weight loss. Any diet can be beneficial, but we must mention that the Mediterranean diet has been shown to decrease cardiovascular mortality and type 2 diabetes, and the DASH diet has been shown, as we all know, to decrease blood pressure. But any diet, as long as it's something which is sustainable, and that is a problem with diets. A lot of them are not sustainable. There's time-restricted eating, which we can use in combination with diets, which may be more helpful. And so we should plug that to patients, because bang for your buck, your patients are going to get more weight loss with diet alone than with exercise. Of course, exercise is also very important because it helps to maintain weight loss. It helps to reduce abdominal fat. It definitely increases cardiorespiratory fitness. And so we recommend moderate levels of exercise, as I stated before. But if we're going to look at diet and exercise, you must get to your diet as well as your exercise. So we know that the skeletal muscle is the most insulin-sensitive tissue, and it's a primary target for improving insulin resistance. So the impact of exercise on insulin sensitivity is actually only evident for about 24 to 48 hours and disappears after 3 to 5 days, which is why it is so important that we perform regular physical activity to improve insulin resistance. The benefits of behavioral therapy cannot be overstated. This particular study looked at persons who were able to maintain their average weight versus those who relapsed to greater than 20% of their weight. And we found that it was found that those who were able to maintain their average weight, 90% were doing regular exercise, 95% of them were able to problem solve. The majority had social support and a personalized diet, versus the others who are not able to maintain their average weight. 67% of them exercised in a limited fashion, 90% found excuses, and 62% had limited support, and 70% were emotional eaters. So these are big things, and behavioral therapy is very important in addressing these. So this is just meant to show you how complicated the whole pathophysiology of obesity is, and that we're gaining ground in addressing the complexity and in providing coming up with targeted treatment to really hone in on all of these areas in terms of the pathophysiology of obesity. These are the FDA-approved medications, and we have none in Jamaica. Let me just start with that. And, every time I do a presentation like this, I really have to make a plug for this, because we have 1 in 2 Jamaicans suffering from overweight and obesity, cardiovascular disease, leading cause of death, and we don't have pharmacotherapy. Orlistat is not readily available. So when we are looking at choosing our medications, we have to think of current access, cost, supply, and long-term accessibility. We usually would want to start with more affordable medications in a stepwise fashion. We need to look at the amount of weight loss we need for health improvements, which we spoke about earlier, and we need to look at non-medication options. So going back to Orlistat, which is a lipase inhibitor, significant side effects, flatulence, oily stools. I've not been able to have a patient who was able to stay on Orlistat for more than a month. And looking at just minimal, moderate weight loss, 25% is what we're looking at in 3 months. Basically contraindicated in cholecystasis and results in lowering of your fat-soluble vitamins. Phentermine is not available, but just for knowledge, it's a sympathomimetic amine, acts in several areas of the hypothalamus we showed earlier, reduces hunger, perception, and appetite. It's approved for only 12 weeks, but long-term studies have shown continued benefit without harm. Those are the doses, contraindicated in anxiety states, glaucoma, side effects of headaches, increased heart rate, dry mouth, etc. Looking at about 7 to 10% weight loss. Phentermine topiramate ER is another sympathomimetic plus GABA enhancement, which again decreases appetite, food craving, snacking. Contraindicated again in glaucoma. Effectiveness is reduced in persons using OCPs at higher doses. Similar side effects as phentermine, looking at about 14.4% weight loss in those who are able to get to the highest dose. Naltrexone bupropion ER or Contrave is another, it's 2 drugs in one, as we know, titrate from 1 tab daily to 2 tabs twice daily to a max dose of 32 and 3360 milligrams. has a synergistic effect on hypothalamic control of pleasure derived from eating, contraindicated however in seizure disorder or anybody at seizure risk, uncontrolled hypertension, and those using opioids. Again, side effects of headaches, dizziness, nausea, and weight loss, about 8%, sorry, that's a typo, in those who are able to get to the highest dose. Now, the glucagon-like peptide 1 agonists, as we know, these are a class of diabetes drugs initially, primarily for the treatment of diabetes. So increasing insulin secretion in response to food, inhibiting glucagon, reducing glucose production in the liver, and delaying gastric emptying, increasing appetite and interest in food. Dose titration about 0.6 to 3 milligrams weekly increase. We don't have it here. Contraindicated in medullary thyroid cancer, MAIN-2. GI side effects are significant, headaches, fatigue, looking about 9.2% of weight loss. Semaglutide, which, basically is making all the rage along with Mounjaro now, is a GLP-1 agonist. And we know that it's dose titrated from 0.25 milligrams up to 2.4 milligrams. There's a weekly increase, 4-weekly increase, so once a week for 4 weeks, then go up to another dose as tolerated. Approved long-term doses are 1.7 milligrams and 2.4 milligrams, contraindicated as liraglutide in men and medullary thyroid cancer. Side effects, GI mainly, constipation, headaches, fatigue, hypoglycemia, muscle loss because of the rapid weight loss. And we're looking at about 16.9% weight loss for tirzepatide or Mounjaro, which is a GLP-1 GIP agonist. Basically, the GIP effect is additive. The exact mechanism is still unclear. There's improvement in insulin sensitivity, lowering of glucagon, inhibition of lipolysis, and the promotion of lipogenesis. Now, the dose range is 2.5 to 15 milligrams. Again, once weekly injections for 4 weeks, titrate up after based on tolerability. Approved long-term dose of 5, 10, and 15 milligrams. The contraindications are the same as GLP-1 and similar side effects, looking at, however, weight loss of about impressively 22.5%. However, we must know that these weight loss figures quoted are really those under study conditions. And in real life, there's data to suggest that we don't get quite that much weight loss in most patients for varying reasons, for cost issues, affordability as a result of cost, availability, access to the drugs, and side effects. So I have a lot of stopping and starting and, discontinuation. So we may not quite get those, but we do get significant results anyway. And it's important to know that when we're treating our patients, if we're able to access these medications, when we're treating our patients, we must set expectations. Patients come and they expect that. They come and they come by name. They want Zepbound or they want, Ozempic or they want Mounjaro, and they're telling you what they want and they're telling you the dose they want, and they think it's this magic bullet, and they have a wedding to go to and they want to take it for 3 months, and they don't understand it's long-term treatment. So we must set expectations. It's not a magic bullet. Titration may be slower due to side effects, and the treatment effects generally occurs at higher doses, especially for those with insulin resistance and the metabolic syndrome. Plateau happens, it varies widely. If you stop it, you need to resume at a lower dose to get acclimatized again. Must stress the increased protein intake while on these drugs, 60 to 80 grams per day. Drink a lot of water. Strength exercises twice per week, because we don't want the Ozempic phase, the muscle loss that it occurs with the rapid fat loss. And there are benefits of these drugs. Every day there's another benefit: cardiovascular disease protection, reduction in inflammation with impact on Parkinson's, Alzheimer's, blood pressure reduction, delaying progression of CKD, fatty liver improvement, kidney disease improvement, sleep apnea. And just recently I heard another benefit in terms of reducing the occurrence of peptic ulcer disease. So every day you get to hear another benefit of these drugs. We do know that definitely they are promising, and they've really changed the landscape of obesity management for patients, and a lot of patients have benefited. The number of coming attractions, because as we said, we're gearing and looking at all of the areas in terms of the pathophysiology of obesity that can be addressed with treatment. So there are a number of drugs coming up, but most importantly, the oral glucagon-like peptide ones. I think Eli Lilly and Novo Nordisk have made applications to the FDA. Hopefully those will be out next year. Hopefully there'll be more available. and affordable. We do know, though, from the data so far that we're looking at less impressive weight loss in terms of about, on average, 10.9% in the studies that have been done. So looking at medication costs and availability, important presence and severity of weight-related complications, concurrent diseases, medical history, lifestyle preferences, psychological issues are all important. Efficacy, side effects, contraindications, and interactions and mechanisms of action of these drugs are all important. And then we have surgery for those with severe obesity greater than or equal to 40 or greater than or equal to 35 with comorbid conditions. And we have restrictive types of procedures like your sleeve gastrectomy, which is commonly done, gastric banding, endoscopic sleeve gastroplasty. You have malabsorptive procedures such as your biliopancreatic diversion with duodenal switch, or your single anastomosis duodenal switch, and combination procedures such as a Roux-en-Y gastric bypass and others, where you basically use like a gastric balloon endoscopically placed to create some space or take up space in the stomach. So, I mean, what are people saying?
I am on GLP-1s and I am going public. I am on GLP-1s and I'm not ashamed to say it and say it loud. I am on Roe and let me tell you why. So after my first Kid Olympia, the weight literally just would not come off. I was back on the court and I was in the gym. Oh my gosh, I was eating clean every single day without any big changes to my body. And it was really so frustrating to see the scale always stay the same or not. If it was anything, it was more. Yes, I am on GLP-1s and I am going public. I am on GLP-1s.
Pretty saying, if Serena Williams can't lose weight without assistance, then the rest of us have no hope. That is simply not true. Do GLP-1s help you lose weight? Absolutely. But losing weight for most people is not the issue. Keep the weight off is. And the second thing that bothered me was her saying, and I quote, no matter what I did, running, walking, I'll walk for hours because they said that's good. I literally was playing professional sport. I worked so hard, I ate so healthy, and could never get down to where I needed to be. GLP-1 helped me enhance everything that I was already doing, eating healthy and working out. Here's the problem. GLP-1s will make you eat healthier, work out more, walk longer, or burn more calories. They simply make you eat less. And because you eat less, you lose weight. Now let's go back to her quote. I would walk for hours and I would eat healthy. She said everything except what actually leads to weight loss, which is eating less. Now I'm saying this, leave it alone. It is your life.
Yes, I am on GLP-1s and
Right. So in conclusion, just to reinforce what was said just now, that like we're looking at not just pharmacotherapy, lifestyle is very important. The GLP-1s are very important in the whole landscape of obesity management in this day and age. For once, we have medications which are really maintenance therapy. They not help you lose weight, but they help to maintain the weight loss. And so they're designed for long-term use, but they are not magic bullets. And if you're not going to maintain the lifestyle, you may not lose as much weight. And I've seen that in my practice. So it's most important to recognize that the most important contributor to the metabolic syndrome is obesity, predominantly abdominal obesity. The assessment for these patients should focus on mental, metabolic, mechanical, and monetary impact of obesity. Lifestyle changes are the most important management strategies, and pharmacotherapy plays an important role as an adjunct to weight loss, to lifestyle. And of course, for those who need more and who satisfy the criteria, there is always weight loss surgery. Thank you. The two questions we had from the beginning, I guess they will go in the chat and you can answer those. So thank you.
Thank you so much, Dr. Phillips. That was such a comprehensive review of obesity, and it's linked to metabolic syndrome. You took us through the importance of the different types of obesity, the apple shape versus the pear shape, the multifactorial causes of obesity, the benefits of weight loss because of the multiple complications. And that is more than just what comes in and what goes out. There are so many other factors. We thank you for that very comprehensive overview.
You're welcome.
And I would ask our audience to put any questions for Dr. Phillips in the Q&A section. You could go ahead and look, because I don't know how the time will go later. We will try and answer some of them live, but you could go ahead and look at what is there and answer some of them in the Q&A section as well. So any questions, please put them in the Q&A section. Thank you ever so much, Dr. Phillips, and we will talk to you a little later. Sam, is Professor Carpenter with us, or has she been in contact?
I haven't had any contact, no.
Okay, I don't know if Lena, if you or Dr. Seni have a contact for Professor Carpenter, if you could see, where she is, but in the interest of time, we will proceed with the program, and when she joins, then we will slot her in. At this time, I would ask what our silver sponsor, Medimplex, to make a presentation. We all know how important it is for us to have sponsors to make these webinars, these CMEs possible. And Medimplex is one of the companies that is forever with us, and we are very thankful to them. So at this time, Medimplex, you could go ahead with your presentation.
Greetings, my name is Sasha Dixon, and I am a medical representative with Medimbex Jamaica Limited. Thank you for having me here today, presenting to you just a few of the products that we have in our women's health line. Now at Medimbex, we offer two types of contraceptives. We have the emergency contraceptive, which is the morning after pill, and our oral contraceptives. Emergency contraceptives. As you would have seen, we offer the P2, which is our Postinor 2, and Postinor SD, which is the single dose. Postinor acts to prevent ovulation or fertilization. Please note that it is not an abortifacient. It does not affect an implanted embryo nor an established pregnancy. How is P2 administered? Now, one tablet is to be taken by the female within 72 hours post-coital activity. The second tablet is to be taken by the female 12 hours after the first tablet. Posinor's effectiveness is 95% within 24 hours, and as the time goes by, it will decrease. When it comes to the single dose or Postinor SD, one tablet is to be taken by the female now, immediately, ASAP, after postcoital activity. 10% of your patients may experience bleeding disturbances, nausea, fatigue, low abdominal pain, headaches. Breakthrough or withdrawal bleeding may also occur 2 to 3 days after taking the tablet. In 1 to 10 patients, they may experience dizziness, breast tenderness, diarrhea, or vomiting. Ideally, Postinor 2 should not be used more than once per menstrual cycle. Repeated use reduces the effectiveness of the drug. Emergency contraceptives is less effective than long-term methods. Why Postinor 2? Just to be sure, Postinor. P2 was researched, developed, and manufactured by Gideon Richter Limited, and it was first launched in 1979. That's over 40 years of success, tried and true. P2 is the innovator brand name of this drug quality assurance. And here we have an illustration to let you know what our Postinor 2 and our Postinor single dose looks like. Now let's talk about our oral contraceptives. We have 3 of them. We have our Lindinet, Novinet, and Mistral. Lindinet contains ethinyl estradiol 0.02 milligrams along with gestidine 0.075 milligrams. Novinet contains ethinyl estradiol 0.02 milligrams and desogestrel 0.15 milligrams. And finally, our Mistral contains ethinyl estradiol 0.03 milligrams and Dinogest 2 milligrams. So let's talk a little bit about Lindinet. Now, Lindinet is 99% effective. The gestidine takes a long time to be cleared from the system. It has a sustained drug effect, fewer pregnancy rates due to missed pill, and also very low incidence of adverse effects, very well tolerated. Or Novinate has a positive effect in androgen-induced skin disorders such as mild acne, seborrhea, hirsutism, and alopecia. Positive effects are seen in case of dysmenorrhea, as well as changes in body weight were non-significant. Now, when it comes to Mistral, Mistral is 99% effective. You're providing your patient with good cycle control, reduced intensity of menstrual bleeding, decreased duration of menstruation, reduced frequency of dysmenorrhea, as well as anti-androgenic effects, used in mild to moderate acne, hair, and skin greasiness. Next on the list, we have our Cleon D vaginal tablets. This contains 100 milligrams metronidazole and 100 milligrams of miconazole. Cleon D vaginal tablets are indicated for the vaginal treatment of urogenital trichomonas infection, bacterial vaginosis, as well as local therapy of candidiasis. How is Cleon D vaginal tablets inserted? One vaginal tablet is slightly moistened and inserted high in the vagina at bedtime for 10 nights. Alternatively, 2 tablets can be inserted at night for patients who are not pregnant for 5 nights. Cleon D vaginal tablets are also safe in pregnancy. Now let's talk about Mycocyst. This is our brand of fluconazole. Now with Mycocyst, you're providing your patient with systemic administration, broad spectrum, it has excellent pharmacological parameters, good tolerability, simple administration, which is our comfort therapy, as well as cost effectiveness. Now as you see, our Mycocyst is offered in 2 different strengths. We have a 150 milligram strength and we also have a 200 milligram strength. Now we speak about this comfort therapy. What is comfort therapy? Comfort therapy provides better cooperation between you, the physician, and your patient via a single weekly administration. So let's take a look at, for example, our treatment on onychomycosis. The treatment for onychomycosis is one single 150 milligram capsule once per week until the nail grows out, ensuring compliance for your patients. Next, let's look at pityriasis versicolor, where the treatment for that is 2 of the 150 milligram capsules once per week for 2 to 4 weeks. Very simple, very compliant patient. And finally, we have our Sorbifol Duros. This is our iron supplement. It contains 320 milligrams of ferrous sulfate, 100 milligrams elemental iron, 60 milligrams ascorbic acid, provides slow release technology, and is quite affordable at an approximate cost of $28 per tablet. Now, Sorbifol is indicated for prophylactic treatment of iron deficiency, as well as therapy for latent and manifest iron deficiency, otherwise known as anemia. How do you take Sorbifol? Now, the average dose for adults and children over 12 years old is 1 tablet 2 times daily, swallowed whole with a glass of water, half glass of water, at least 30 minutes before meals. This can be dosed once a day also if the anemia is mild. However, in pregnancy, there is a little adjustment. During the first 6 months, a single tablet is to be taken once daily, and in the last trimester, as well as during nursing, 1 tablet is taken 2 times daily. So why Sorbifol? Sorbifol provides gradual but an even release of the active substance for 6 to 8 hours. It facilitates comfort dosing. There is a less chance of constipation due to slow release of ingredients. Also, less GI irritation due to the slow release of iron. Faster absorption of iron due to the vitamin C. Tablet is a small size, it's odorless and affordable. Thank you very much for having me here today, presenting to you on just a few of our products, and do enjoy the rest of your evening.
Thank you very much for that presentation and for your continued
Excuse me,
support.
Doc. Sorry, 1 second. Ladies and gentlemen, please allow me to support the introduction of our wonderful moderator for the second session. She's too kind, Dr. Aileen Standard Golson, family physician and an executive board member of the Caribbean College of Family Physicians Jamaica chapter. Dr. Standard Golson is a respected family physician whose career spans clinical practice, leadership, and advocacy in primary healthcare. She's deeply committed to strengthening the role of family physicians in Jamaica, ensuring that communities have access to continuous, comprehensive, and compassionate care. In her capacity as executive board member of the CCFPJ, Dr. Standard Golson contributes to advancing education, mentorship, and professional standards for physicians. She is especially passionate about promoting collaboration within the health sector to build stronger healthcare delivery systems for present and future generations. Your moderator for the second session, Dr. Aileen Standard Golson.
Thank you very much, Mr. Herod. All right, so that was the presentation from Medimplex, and again we thank them for their contribution. I have not seen where Prof. Carpenter has joined us. I don't know if anyone has been able to get in contact with her, but I know that Dr. Mark Minot is with us. I've seen him from the beginning of the set of the webinar, and we are glad to have him here with us today. Dr. Mark Minot is a consultant orthopedic surgeon at the Spanish Town Hospital, a role he has held since 1998, despite his youthful appearance, an orthopedic surgeon and sports medicine physician to the Jamaica Football Federation since 2008. He holds the MBBS and DM Orthopedic Surgery from UWI, is a fellow of the Royal College of Surgeons of Edinburgh, and completed a diploma in sports and exercise medicine from the University of Wales. His clinical interests include trauma, complex reconstruction, arthroscopy, and hip and knee arthroplasty, with a strong focus on returning patients, especially athletes, to safe, high-functioning activity. An associate lecturer in the Department of Surgery at the UWI, he has contributed to undergraduate and postgraduate training and presented widely across regional and international orthopedic meetings. He is a past president of the Jamaica Orthopedic Association, vice president of the Caribbean Association of Orthopedic Surgeons, and an international member of the American Academy of Orthopedic Surgeons. Please help me to welcome Dr. Minot, who's going to speak to us on osteoporosis, the new epidemic. Not sure if it's a full stop or a question sign after that, but I'm sure that after he presents, we will know whether in fact it is a new epidemic, yes or no. Dr. Minot, over to you.
Thank you very much, Dr. Eileen Standard Golson. Good afternoon, everyone on the webinar. I'd like to say quick thanks to the Caribbean College of Family Physicians for being given the opportunity to speak this afternoon on osteoporosis, the new epidemic. Oh my. Right? So the real question is, why should osteoporosis matter today? How big a problem is it, and how relevant is it in our life? Well, this morning, I will talk about osteoporosis, the consequences of having osteoporosis as a diagnosis, prevention strategies, and we'll touch also on treatment options. And hopefully at the end of the presentation, you have an appreciation that this is really a silent epidemic, which is going to bite us in the end, very similar to how hypertension is asymptomatic until the person presents with cardiovascular complications. So Osteoporosis is a disease characterized by low bone mass and structural deterioration of the bone tissue. The World Health Organization defines it as having a bone mineral density that lies 2.5 standard deviations below the average density for young, healthy women, otherwise known as a T-score of minus 2.5. Importantly, it is typically coincident with sarcopenia and are therefore, with sarcopenia, two sides of the same aging skeletal coin. The epidemiology of osteoporosis globally is a very heterogeneous group, and it is difficult to say definitively which feature is most common for any particular feature of osteoporosis. So by looking at the meta-analysis of 86 studies on all continents, we estimate that osteoporosis affects at least 200 million people worldwide between the ages of 15 and 105 years. For example, Iran, of all those countries, was the worst, with an osteoporosis rate of 77.3%. Is it because they wear burqas and they cover themselves from head to toe away from the sun and therefore interfere with their calcium metabolism? And Canada was the best with 1.07%. Is it because of their high exercise culture, where they positively reduce the rate of osteoporosis by way of their lifestyle promotion? So we know that 1 in 3 women and 1 in 5 men over 50 will experience osteoporotic fractures in their lifetime. We know intuitively that osteoporotic fractures are on the rise, and therefore countries that have very large populations, for example, India, will have very large numbers of osteoporotic fractures. When we look at that cohort, we notice that, like everywhere else in the world, there is an increased urbanization of the population. And with that, we note that with urbanization comes a change in lifestyle, which is out of the sun. And 80% of India's urban population have vitamin D deficiency, and hip fractures occur a decade earlier than in Western countries. Bone density declines steadily after age 30 years physiologically, and therefore aging populations, especially with earlier onset of osteoporosis, will see the consequences of osteoporosis. And therefore, as our populations live longer, the problem of osteoporosis will become greater. And that's why we're now considering it a growing epidemic. Many of us who have been in practice of medicine for the last 40 years will recall that if you're a 70-year-old and the life expectancy when I was a medical student was 71 for men and 73 for women. Now it is quite common to live to 85, and it's not that impressive anymore to live into your 9th decade. So definitely, we now have a population which has the capacity to live longer. Truthfully, there are some risk factors for osteoporosis which we can do nothing about, such as your age and increasing age. You really don't have a choice about whether you're male or female. And genetics are something you're born with. So though these are risk factors, there's not much we can do about your genetics or your family history. But nonetheless, we should note that. We do have control, however, over lifestyle risk factors. So we should pay attention to smoking, alcohol consumption, our level of physical activity, so that we can optimize our stress to the skeleton and to maintain bone mass. And I know we had a very good talk by Dr. Karen Phillips on the problem of obesity and the need to exercise. But thin bodies also have a higher risk of osteoporosis, particularly in the women. And many of the family physicians who are engaged in treating girls with anorexia nervosa, which are very distressing disorder when they present, they have a very low um, body weight, and they have very low fat content in their body, and therefore they have low estrogen levels. And they also present with osteoporosis at age 15 and younger, and they will also get osteoporotic fractures as a result. Obese bodies also have a higher risk of osteoporosis, and perhaps that's related to their other lifestyle contributions. So then there are nutritional risk factors. Calcium and vitamin D deficiency is definitely on the rise. Most individuals in the population do not take supplements, but with increased urbanization and reduced contact with the sun, even Black people are experiencing poor calcium metabolism. Inadequate fruit and vegetable intake, excessive protein and sodium and caffeine is said to increase the risk of osteoporosis. And of course, as mentioned before, maintaining a very low body weight puts you at increased risk, most likely related to your reduced estrogen content. So, continuing on that theme, the hormonal factors surround estrogen levels for women, and therefore menopause is definitely a risk factor for rapid loss in bone density. And for men, at the same period in the sixth decade, as their testosterone levels begin to fall, their risk factor for osteoporosis begins to rise. I will show a slide later talking about estrogen, the physiological fall in density with regards to age. But menopause can be physiological or it can be surgically induced. For example, oophorectomies along with hysterectomies will cause you to have early onset menopause and therefore increase your risk of osteoporosis at an earlier age. So here we have a slide which shows the physiological change in bone density with age. As you can see, in the red, the pink, that is the change in bone density up to age 30. It peaks at age 30 for men and women, and then thereafter it's downhill all the way. The downhill change in density is, however, affected by your lifestyle. So if you pay attention to your diet, you engage in resistance training exercises, then you're more likely to have a shallower slope. But if you were to not pay attention to your disease modifying activities, then you'll have a steeper slope. And since we plan to, the evidence is that we will live until we're 100, then the risk of osteoporosis becomes greater, or rather, the potential population with osteoporosis will rise. So it's all about balance. So whereas we have no control over our genetics, which refers to the possession, the relative amounts of rank and rank L genes, which concern estrogen receptors in our body. We have very little control over cellular and microarchitectural changes induced by environmental factors like radiotherapy. For the normal person, it's a matter of balance between bone loss and bone formation. So on the one hand, you have increased activity and exercise, good calcium metabolism, to name a few, being a positive risk factor for bone growth, and whereas inactivity and lack of vitamin D or calcium being a cause for bone loss. To name some risk factors. So how do we diagnose osteoporosis? Well, that's the thing. It's a silent disease until the fracture occurs. The fractures are typically low energy fractures, such as falls from a standing height, and or any injury where the amount of force applied ought not to result in a fracture, but it does. In the case of the spine, it will cause they present with back pain, and the affected vertebra that has fractured can fracture and compress with loss of height. This loss of height will continue until the fracture heals, and if it compresses more than 50%, then the change in orientation of the spine is such that the kyphosis created will cause increased stress on the adjacent vertebrae and therefore lead to an increased risk of more vertebral fractures. And after a while, you get a kyphotic deformity of the spine. And therefore, cartoon caricatures of the elderly always includes the elderly with a stooped posture with height loss. Hip fractures, many of them are intra-articular and will not heal because they have no blood supply. So the optimum treatment for these are operative. And in terms of the spine, I spoke about the risk of collapse. But if you were to see someone who has an acute fracture of a vertebra and an old fracture of the vertebra, then that is the definitive clinical evidence that you have osteoporosis as a diagnosis. Osteoporosis typically affects the wrist as well, and the poorly mineralized and less dense bone of the distal radius frequently fractures with comminution, with an inability of the distal radius to be reduced back to its original length and maintain the length if manipulated. So these patients will heal with a malunion unless operated on to hold them in position. So many of these fractures, therefore, have a direct economic burden. In our Jamaican literature, there's not much data, but Kenneth Vaughan in 2014 presented a very good analysis of the cost of osteoporosis in Jamaica. And at that time, it was estimated to be about 46 million just to treat hip fractures alone. In the United States, it's about $50,000 per patient with an annual cost of $5.96 billion for hip fractures alone. In the UK, the NHS estimates are about $2 billion to treat 255,000 falls per year. So it's a very expensive problem, and that's just for hip fractures alone. So, and that doesn't include wrist and spine, which also have their own issues economically. So here we have a slide showing you the distribution of osteoporotic fractures. As you can see, hip fractures occupy the lion's share at 50%, but there are another big chunk is a non-vertebral fracture, 31%. And that includes the humerus fractures, the fragility fractures in the ankle, fractures of the radius, the pelvis, tibia, and then you have another chunk for vertebral fractures, the 14%. And then there are quality of life issues. So many people, when they hear they have a vertebral fracture, they present because of pain, and they once they have failure or pain to resolve over time, they present to their family physician, and some physicians would then refer them to orthopedic surgeon because of failure to control the pain. In some cases, they will heal without too much deformity. In others, they will fail to heal or continue to lose vertebral height and therefore put themselves at risk of future fractures. And therefore, the optimum thing to do for them is to stabilize the vertebral fracture by doing cementation of the spine on the image guidance so that they do not have collapse beyond 50%. As you can imagine, if you have a vertebral fracture and you can't turn in bed, you can't get to the toilet, you can't get to sit out to have a cup of coffee, then you will get reduced independence as you fail to do activities of daily living. So reduced independence is a problem. In terms of hip fractures, if your hip fracture is such that you cannot ambulate and you are stuck in bed, that becomes a problem too, because now you can't care for yourself. And simple things like mobilizing from the bed to a chair or mobilizing to the bathroom becomes a challenge. And if the elderly are stuck in a bed with a painful hip, the sequelae of DVT, pulmonary embolism, urinary tract infections, bed sores become a real risk, and therefore morbidity and mortality becomes a big problem for the family and the patient. So there is a high healthcare cost for the treatment, for the intra-hospital treatment and rehabilitation. There's also a high cost for non-fracture treatment because home care with paying for caregivers for disabled patient who can't care for themselves, and then having to cope with the inevitable complication of DVT and pneumonia and UTIs, PEs and bed sores is expensive. So therefore, we have a case to actually spend some time to examine ways to improve comfort and reduce cost in the at-risk population. So who's at risk? The most important clinician, therefore, in this algorithm is the family physician, the people on this chat. They need to be vigilant in identifying those persons, particularly the females, who have chronic illnesses, who are steroid users, such as asthmatics and people who have rheumatoid arthritis or any other immune-related disorder requiring use of steroids, relatively inactive individuals, individuals who have a family history of fractures and therefore have a genetic basis for osteoporosis. These are the people who need to be identified by the family physician when they are young. I'm talking about people in their 30s and 40s, which needs to be identified from then and educated on their risk. And therefore, that is when we need to start thinking about bone mineral density testing, the DEXA scan, which is the gold standard for evaluating bone density. The WHO, as I said before, utilizes a T-score of less than 2.5 to diagnose osteoporosis, where the yellow meets the orange. The yellow band is osteopenia, and that would be your at-risk group. This slide shows the same data, but the blue in the middle represents 95% of individuals who are on either side of the median, and their physiological loss in density with time. So if you were to cast your eye to the very top of the scale, those individuals can reach 100 years of age and they're barely entering the osteopenic category. Whereas in the lower side of that blue band, by the time they're 70, they're at least osteopenic. And many of them are now entering the osteoporotic range. So prevention strategies, it goes without saying that it's always easier and cheaper to prevent rather than treat any disease process. So lifestyle modifications is where it's at. We must start in the third decade of life when the patients are optimal to reduce the rate of bone loss over time. We must have a conversation about diet and exercise, and we must try to avoid smoking and alcohol use in excess. And in excess is defined as more than 4 units of alcohol per day. The importance of exercise is enforced in primary and secondary schools, after which it becomes optional in Jamaica. This takes advantage of the physiological tendency to increase bone mass up to age 30. Thereafter, bone density will decrease over the rest of our lifetime. So weight bearing and resistance training to strengthen the bones is a must in order to reduce the rate of bone loss. I refer you back again to this slide of balance, where we can try to address the things that are within our power, which is nutritional as well as exercise. So calcium metabolism is important, and adequate calcium intake, which is related to your age as well. So you only need 1 gram of calcium per day, but the elderly have an impaired ability to absorb calcium from the gut. So they should supplement either by supplements or increasing the intake of calcium containing foods so that they can have between 1.3 to 1.5 grams of calcium in their diet. Pharmacologically, though, for those who are definitely at risk, like osteopenic and the osteoporotic people, the bisphosphonates, whether it be oral or intravenous, are the way to go. That's the #1 method that we have as a pharmacological option now. The cost per year is about the same, whichever one you choose, but clearly the intravenous version, a cluster, is going to give you, for the same cost, maximum compliance as it is a once-a-year injection. Calcitonin is also used in established osteoporosis to reduce spine fracture risk and reduce pain by increasing bone density at 2% per year, but nonetheless, it is still inferior to bisphosphonates. And like bisphosphonates, it seeks to reduce the activity of osteoclasts and therefore, on balance, allow you to have an increased bone density. Selective estrogen receptor modulators, example, raloxifene, and tamoxifen are probably the two which are most popular for treating severe osteoporosis. Those who have bone density greater than 3.5 to 4. And that is related to its effect on the estrogen receptors, which brings me now, segues into hormone therapy. Hormone replacement therapy utilizes the effect of estrogen on bone mass, and it may reduce the risk of osteoporosis, but it has potential side effects. So the most important group where H or hormone replacement therapy could benefit is the early menopause group. Those who have had procedures involving their ovaries. It will reduce symptoms and it will permit exercise by reduction in the symptoms and therefore benefit the maintenance of the skeletal frame. It's not a risk-free option because there is an increased risk of breast cancer, DVT, and embolic events with HRT, and it should not be utilized as a cure for osteoporosis, but it is definitely an option to maintain bone density for those who are using it for early menopause. Newer drugs like Prolia, now denosumab, reduce the risk for vertebral and non-vertebral and hip fractures in patients who are unable to comply with bisphosphonates and have a T-score greater than 3.5. The independent risk factors that they talk about in this slide are a parental history of osteoporotic fractures, alcohol use more than 4 units per day, and rheumatoid arthritis. And this table is what is used to indicate those who may be treated with Prolia. Romosozumab is a monoclonal antibody. All the anabolic agents are not available in Jamaica. So, public health perspective, I think, is probably the most important single thing that we can add to armamentarium. And in 2000, the American Academy of Orthopedic Surgeons had an initiative to declare the decade 2010 the decade of the bone. I'm not sure how far that transitioned to Jamaica. I didn't see much in Jamaica. But as a general statement, in my opinion, the general public is not aware of the problem of osteoporosis and how their behavior can impact their elderly years. That said, awareness programs globally have been very effective. Notwithstanding those comments, in Jamaica, governmental organizations need to be made more aware of the savings to be made by reducing the prevalence of osteoporosis. In Jamaica, the rebranding of Ministry of Health to Ministry of Health and Wellness, with several promotional activities in social media and exercise-oriented events, have been a very effective program for cardiovascular health. And by implication, those efforts will benefit osteoporosis prevention as well. The government can also insist on an increasing green space in urban areas and provision of cycling and walking trails, and as tools to help to encourage exercise. So our programs, though directed at cardiovascular health and not bone health, the benefits are synergistic. As we talk about women in this forum, please don't forget that men get osteoporosis too. And though women are much more affected by osteoporosis, men remain underdiagnosed. This is a slide of a lady who is quite close to me, and she slipped and fell and she stepped off of her bed and had a painful right hip. You can see the subcapital fracture neck of the femur, and she was 95 years old. And the question was, what do we do? So she was advised to have surgery in order to get her mobilized again. And the family said no. She's never had surgery before in her life, and they're going to manage her at home with caregivers rather than manage her with surgical intervention. Within 3 months, she died, having had bed sores and pneumonia. So the decision for non-operative intervention in cases like this is what we're trying to avoid. So having obtained osteoporotic fracture, it is important that the family physician be part of the team that understands the relative risks of both prevention and treatment. So, and in cases once they actually present with osteoporotic fractures, the orthopedic surgeon needs the support of the family physician to optimize the return to normal function if she had done her surgery. So at age 95, if she had her hemiarthroplasty today, she'd be walking full weight bearing tomorrow. And therefore, that should have been the right thing to do. So challenges in management concern patient compliance with the need to exercise, observe nutrition, good nutrition, and in some cases, the cost of medication like bisphosphonates and the long-term adherence with the various protocols. We need to have a clear understanding of the treatment options if there's a fracture, and the family physician is integral in that. We need to probably improve our research on genetics and their role in osteoporosis, improve our diagnostics for it. And therefore, I call on all family physicians here on this chat to be part of the team to educate our patients on their risk factors from when they're young, so that they do not deteriorate too far down the slope of a low bone density. I want to thank everyone for their attention and invite you all to the Caribbean Association meeting on October 3rd at AC Marriott, when we'll be having our 20th anniversary meeting. Thank you very much.
Thank you very much, Dr. Minot, for a very clear and comprehensive overview. So we did see, in fact, that osteoporosis is indeed on the rise and a significant issue. You reminded us of the clinical features, but beyond that, you spoke about the economic burden caused by the complications or the events that can occur with osteoporosis. And you also spoke about the effect on the quality of life. Also, importantly for this group, you reminded us of the importance of the family physician in screening for osteoporosis from an early stage, and also for patient education, again, early on. So we thank you very much for that. And if there are any questions, I'll ask you to put them in the Q&A, and I'd ask Dr. Minot to take a look to answer what he can, answer some in the Q&A space, and hopefully we will have time to also entertain him answering some verbally later on. So Dr. Minot, thank you very much for an excellent presentation.
Thank you.
Professor Carpenter,
I believe Prof. Carpenter is here now.
Right. Is there another sponsor presentation later or not?
Yes, we have one more sponsor presentation that's listed for Medipex.
I will take it
But I think we can do that after. Yes.
I'll take that after Professor Carpenter's presentation. So Professor Karen Carpenter is head of the Institute for Gender and Development Studies Mona Unit at the University of the West Indies, a licensed counseling psychologist in Jamaica and Florida board-certified clinical sexologist. She bridges rigorous scholarship with frontline clinical practice. Professor Carpenter also directs the Caribbean Sexuality Research Group Clinic at the University Hospital of the West Indies, where she leads care, training, and research at the intersection of gender, culture, and sexual health. A published author, She also hosts a popular online program, Love and Sex, engaging regional and diaspora audiences on intimacy, relationships, consent, and wellness. Known for her clarity, evidence-based approach, and accessible style, Professor Carpenter is frequently sought after by policymakers, educators, and media for insights on gender equity and sexual health. It is our distinct pleasure this afternoon to welcome her to speak on the impact of female sexual dysfunction on women's well-being. Professor Carpenter, over to you.
Thank you so much for the invitation, and thank you for that sometimes when I'm introduced, I don't recognize myself. So I think it happens to most of us. I would, however, like to correct one thing, which is I am no longer the head of the Institute for Gender and Development Studies. We have the very able Dr. Delia Bean, my colleague, who now heads the unit, but I'm very happy to have headed it for as long as I did. Thank you. So I want to jump right into it. Do I have share privileges?
Yes, you
Yes,
should.
Doc. Yes, you do.
Thank you. Okay. So let me just move to play from start. And I'm mostly interested in the psychological factors, of course.
Doc, you're not sharing yet, though.
Oh, I'm so sorry.
That's okay.
Apologies. Excuse me. I think I jumped ahead of myself.
Yeah.
Share. And here we go. And please tell me if you see my screen.
Yes. So then we just go to full screen, and there you go. Perfect.
Okay, so I'm mostly interested, obviously, in the psychological factors, and I think for us to understand the impact of these things on women's well-being, on anyone's well-being, we have to understand and begin with definitional terms. What do we mean when we say the impact on people's sexual response? Because how one person may define sexual response may be quite different from another. And from a psychological perspective, we're going to be looking at the whole person. We're not just looking at whether or not the person achieves an orgasm, which many people are after. That seems to be the destination. You know, if we're on a train, we're all heading for Orgasmville. But in psychology, we're also interested in whether or not the person experiences distress and whether or not they experience comfort and well-being. So all DSM, and that's a diagnostic and statistical manual, which is used in psychiatry and psychology for diagnosing issues, all DSM categories are followed by a little notation at the bottom that says, and causes distress. So a condition may be present that does not cause distress, is not harmful to the body, and therefore the condition goes unnoticed or unreported, or the person experiencing it, the female experiencing it, may not have any need to remedy the condition. So when we as psychologists see them, it's when it causes distress. Sometimes the distress is caused to the partner and not so much to the individual experiencing it. Because again, when we look at human interaction, we understand that when two or more people come together, it's about more than the two or more people. It's about that relationship in the middle. So a partner may be affected by the female partner's sexual dysfunction, and they may be the one who is reporting it. And that often happens in psychology, where the person receiving the distress is the one reporting the issue. So let's look at the overview. I always want to take people through the sex cycle. It's really important for us to understand what the phases of sexual function is. I think in lay language, when we say sex, we often think intercourse. For a sex therapist, intercourse is only one of the courses. There are many courses. There's intercourse, outer course, and all the other courses that make up sexuality and the sexual response cycle. Not all sexual activity that brings pleasure, that brings desirable comfort to partners is necessarily intercourse. And certainly with aging, we look at some of the other ways in which people can experience the pleasure. I'm going to just lower my video so that we're not, I find it a little distracting to watch myself talk. So I'm going to just put that at the bottom, if you don't mind, so that we can focus on the slide. So this is what I always want to talk about. And we could talk about the sex cycle for a very long time, because in each person, these four little buttons that we talk about mean different things. So when a sex therapist speaks about sex, what we mean is the completion of the sex cycle. We're not speaking about intercourse. Okay. The sex cycle begins, if you like, at 9 o'clock. I have to look at my watch to know. At 9 o'clock with desire. And unlike what most people believe that desire occurs in the body. It does not. Desire occurs in the mind. So the mind has to want sex. The mind sees something sexy, has a sexy thought, has a sexy memory, sees a partner who they find sexually attractive, and the mind says to the body, hey, let's get ready for some sex. Yes? So desire is between the ears, and this is an important issue. When our libidos drop, so does our desire. So if a person, male or female, but here we're talking about females, has experienced a drop in libido, then their desire wanes, and their desire for sexual interaction may also wane. And this is not always hormonal. Sometimes it is, but you'll find that it's an interaction between the environment and the individual, the internal and external environments. So if we have desire and the desire is sufficiently strong, the body begins to enact arousal. So first it's between the ears and then between the legs. In that, the brain tells the body, get ready for sex. And that means that the blood rushes to the genitals, male and female. The blood rushes to the surface of the skin, which is why you tingle. This is why when you're touched during arousal, it feels that much more exciting. And we have all the other physiological changes that take place, including the tautness of the nipples, the flushing of the body in certain portions. And this tells the body, no, let's lubricate, let's get ready. We know that as we go through the aging process, for some women, and I might want to emphasize not for all women, for some women, dryness occurs. We have ways of addressing that through fantastic lubricants that are not just KY jelly, although they've now diversified their range, but lubricants that come in flavors, that come in edible flavors as well, and come with different smells. So we can enjoy that lubricant more than it used to be when it was sort of, and forbid when it was just Vaseline. I'm trying to avoid the idea of using Vaseline at all, so that's why I pause. We don't want to be using Vaseline if we're using condoms, and even people who have passed the point of getting pregnant may want to use condoms for various reasons, including lubrication, because a lubricated condom can be very helpful if you don't want to use your gels, etc. Then we come to the orgasmic phase. If there's sufficient stimulation during the arousal phase, we experience an orgasm. And an orgasm takes place both in the body and the mind, yes, and it also takes place chemically. The body releases some chemicals that aid in that experience of the orgasm, feeling like it's lasting a whole day. No, it's 7 minutes to 15 minutes for the average sex act. So it may feel very long, but the average sex act is 7 to 15 minutes. And once we reach that crescendo, that tensing and release, the brain is going to release some chemicals. It's going to release dopamine, it's going to release endorphins, and towards the latter part of the orgasmic phase, it's going to release oxytocin. And you might know that in women, we have higher levels of oxytocin, and that oxytocin is also released. We'll come to that during breastfeeding for bonding. So the endorphins and the dopamine make us feel dopey, make us feel like it's lasting long. And the endorphins make us feel like we've just had a wonderful bar of chocolate, for those of us who are not allergic to chocolate. And so we have that floaty feeling. It feels like it's lasting long, and we have this sense of immense well-being. Yes? And then the oxytocin kicks in and helps us to bond with that feeling. Now, the feeling is not happening by itself, it's happening with someone present. And so during the coital gaze, that person who is present during the feeling of orgasmic euphoria is the person that we bond with. And that makes us come back for more. And clearly, nature has it in mind that if we come back for more, we have a higher chance of getting pregnant. But even after we are not reproductively viable or interested, the body continues to do its work and bring us back to that orgasmic phase. Then we have resolution or rest. And men generally need more time for resolution or rest than women do. Younger women have a shorter refractory period, we call it a refractory period, as do younger men. As men age, they have a longer refractory period, and some women have a longer refractory period as they age as well. I want us to talk about how it ought to happen so that we can understand the dysfunctions. The sexual dysfunctions in women are not restricted to aging, but we do tend to see greater levels of dyspareunia, pain on intercourse, and that is in part due to dryness at times. At other times, it's due to the fact that you haven't really become properly aroused. So your arousal phase is cut short, and that means that the stimulation that you're receiving may or may not result in an orgasm, because the arousal phase is extremely important to your reaching that crescendo of the orgasm. So we find that with some women, they become anorgasmic. They lose their, I wouldn't say ability, but the orgasm doesn't present itself because it's not lost entirely. Yes? So some women, low desire, some women, arousal is incomplete and they find lubrication difficult, or they may find concentrating on the sex act difficult. They're building shopping lists in their heads or thinking about all the other things that they could be getting done. And this is a fact for both men and women. But I find that in women, often the lack of pleasure that they're experiencing during intercourse has to do with a wandering mind. We have to keep the mind in that activity and focused on the partner in order to achieve sufficient arousal. So we have anorgasmia that might be taking place in the orgasmic phase. In the resolution phase, some women find that their resolution period is very long and they perhaps don't want to have a second round or a second episode of sex, or don't even want other sexual activity. So if sex becomes unpalatable, if it becomes less exciting, if it becomes a chore or a bother, then clearly it's going to result in what many folks have in the past referred to as frigidity. We don't use that word anymore. So it may result in low sexual desire altogether. So you notice it's a cycle, it comes right back to the desire. If we've experienced these other phases in a very wonderful way, then it's likely that our desire will be sparked again. But why would you desire something that is uncomfortable, that's painful, that you don't have a great interest in, and doesn't allow you to achieve an orgasm? So we have to think carefully about those 4 phases when women present and say that they're not enjoying sex, they're not having a good time, or the partner presents and says, my partner doesn't want sex with me anymore. Yes? And I find that often in that complaint, especially when it's coming from the male partner, there's little consideration to the fact that we have to be attractive to our partners. It's not just about does she want sex, it's about does she want sex with you? And we need to understand that if we're in a long-term relationship, we're going to have to do things that keep us healthy, keep us attractive, keep us looking and smelling good so that our partner will want that sexual encounter. Some women complain of not having any foreplay. I find most women aren't complaining about the foreplay. They're complaining more about what happens during the foreplay. Yes? So they're complaining about the fact that I've asked for this or I don't like that, and it keeps happening. So I think there has to be greater willingness to listen to our partners during those phases. Okay, so we have the attraction, desire, eroticism, right? And we looked at that in the desire phase. The interest in your partner. Do you like your partner? And are you attracted to them erotically? You may love your partner and love your partner deeply, but that love could be quite platonic. That love could have lost its spark, or perhaps the nature of the relationship was not one that began with hot and heavy erotic attraction. However, the relationship began, it's going to return to that state when you are challenged sexually. So if the female did not see the male partner as her, I don't know, who's the equivalent now? It used to be Brad Pitt, but I think we can say George Clooney still dishy with his salt and pepper. If that's not your George Clooney, then as you get older, as some of the changes take place in your body, you may not find your partner as attractive as before. It really is an area that we ignore. We don't speak about the fact that we have to remain attractive to our partners. Okay, so that attraction thing. And we talk about desire being wanting to be sexually attractive. In psychoanalytic theory, we talk about the psychic energy of the life instinct in general, or the energy of the sexual instinct in particular. So is that energetic exchange still going on between partners where they're curious about each other sexually, they're intrigued by each other sexually? And of course, that is something that we have to work at. We tend to play down the erotic when we speak to patients. We want to talk to them in a very clinical fashion that sounds like the textbook of sex is 1, 2, 3, A, B, C, and that's sex. And everybody's supposed to be happy with that. We really need to change that vocabulary towards what is the human experience? What is it that excites the person? Because we get excited in the mind before we get excited in the body. Yes, and one of the questions that we ask constantly is, what are your sexy thoughts? Do you have any sexy thoughts? Are you thinking about your partner or the next sex act? Esther Perel, very famous sex therapist and relationship therapist, says that the couple that is erotic and enjoying fabulous sex throughout their lifetime, that they begin thinking about the next orgasm immediately after the last one. And what she really means by that is that couples who are an erotic couple will be referencing the last time that they were together sexually. And it may not have been intercourse, but perhaps they were deeply aroused by each other, or a partner was deeply aroused by what the other partner was doing. And this becomes part of their conversation. So it acts as a kind of teaser to the next time that they engage sexually. And that is definitely a hallmark of the erotic couple. It's not, oh, it's Friday evening, let's get in bed and have sex, or it's Sunday morning, and I know Sunday morning has gone, so those of us who did the Sunday morning sex has happened already. Yeah? So simply scheduling it is not enough, although scheduling sex is not a bad idea. We want to be engaging our partner in that conversation about what feels good, what do we still like. You still turn me on. I turn me on when I see you in this outfit or that outfit or dress this way, or when you do these things. That's a conversation that we've made very taboo, except for young people. And I don't understand why, when we know our bodies better, we speak less about our bodies. Yes, we have to encourage that in couples who have been together a long time. Okay, so yes, we do know that age affects women's relative capacity for sex in an inverse fashion to men, in that, I don't know again why we don't ever speak about this, women who are no longer in fear of getting pregnant may experience greater sexual desire because they are now able to have sex at any point in time. There are no periods to interrupt, no menses to interrupt when you can have sex, and there is no longer the risk of pregnancy. Your estrogen, progesterone is relatively lower than your testosterone would have been. And men, on the other hand, have a diminished testosterone, and we're not necessarily seeing anything that might increase the libido. But in women, we have the reverse issue, that now you don't need to worry about pregnancy. And if you're lubricating, and many women do lubricate post-menopause, the ones that we see in the office are the ones who are having difficulties. But the great population of women do not come into the offices. It is a minority who seek out cures, if you like, treatment for issues such as that. And there are too many products on the market right now that can help us. For us to say lubrication is the issue. Thinning of the vagina, the lining of the vagina may well be, and that needs to be addressed early. But I see there's a talk on HRTs, which will be very, very useful for that discussion. And we want to look at those lowered orgasmic responses in some women. Some women find it's a lot harder to achieve an orgasm. But like I say, orgasm seems to be a destination. We're not content to engage sexually when no orgasm is in sight. And I think that's a fairly short-sighted way of looking at sexual interaction in a couple. So what are the other ways that we can make sex pleasurable for the female? And little attention is paid to the clitoris. Little attention is paid to anatomy, except where it comes to reproductive anatomy. And many of our male and female patients and clients do not even know where to find the clitoris, what the clitoris is, how it functions, that the clitoris has feet, and that often stimulation in the vaginal canal is going to be related to the feet of the clitoris being deeply embedded in the anterior wall of the vaginal canal. Yes? So if we know more about our bodies, we're likely to derive more pleasure from the act. And I find that a lot of what happens in sex therapy when we're not having that great sexual experience is psychosexual education. It's helping men and women understand their bodies and how the body can experience greater pleasure. I'm a very, very firm believer in the Kegels or Kegels, as the Americans call it. Yes, because both for men and women, this gives us greater control of the muscles. It gives us greater pleasure. Sex is an active encounter. It's not a passive act where one person does and the other one receives. And women who can, in fact, engage the muscles that in the floor of the vagina tend to have a better experience of sexual contact and experience less anorgasmia because it is a participatory activity. It's not a passive activity. Yeah. The resolution phase, the res phase, this is when we have that cuddling, as some people like to cuddle, some people like to just lie there with a partner. And this resolution phase, when we've achieved the orgasm and we're coming back down from that high, is when we have what we call the coital gaze. And that coital gaze is about 5 inches from your own face. Yes? And that coital gaze is repeated when we breastfeed. So we're giving that coital gaze to our partners during sex, and that's when the oxytocin is being released. And then we have that same gaze in the breastfeeding phase, and the oxytocin is being released. So it makes it easy to understand why you bond with a partner if you've enjoyed good sex with them, because that oxytocin is helping you to bond. And it's easy to understand how that's transferred to the infant when we breastfeed, because again, we want to keep that infant alive. And so nature has its way of making us bond with that infant and experience warmth and care and wanting to take care of the other person, a very tender moment. So I encourage partners not to jump out of bed the minute you've achieved an orgasm, but to really enjoy that phase, that postcoital phase, because it's quite important to the bonding. And I think it leaves us better disposed to engage with our partners and ask them what they enjoy, what they don't enjoy. Yeah? So, I've put here, this has implications for the female partner whose libido may be higher or more varied than the male partner. And this is true. There are women who, as they age, find that they can be pleased in a variety of different ways other than penetration. And the male partner may see penetration as the goal, that if there's no penetration, then wow, we've not really enjoyed ourselves. So we want to open up both partners to the idea that penetration is not the only way to enjoy sexual contact. And that adds some variety for us as we get older. See if I can get to move. Okay, and I already described this, how we fall in love with the big O. We fall in love with the orgasm, and the orgasm, if it's attached to a person that we're positively disposed to, it means that we're going to want to come back again and again and again to have that experience with that person. Yeah? The coital gaze, the oxytocin, and the orgasm working together, nature very efficiently putting us in a position to come back and have more wonderful sex if we've had good sex. Okay, so pain site memory. And this is an interesting case that I came across very, very early in my practice. And I had a client who had a medical menopause. She had a full hysterectomy, and her partner, they were not married, had a common union. Her partner was very concerned that although she had gone through the treatment for the endometriosis, although she had had a full hysterectomy, she was still complaining of pain. And I had a conversation, in fact, with one of the fertility doctors, and that discussion led to the question of pain site memory, that she had become so used to clenching, to contracting all her muscles, to being tense when penetration occurred, that she was having pain site memory. So her dyspareunia, pain on intercourse, was really caused by her not being able to relax during penetration. So that was a whole process of getting him to understand her pain and getting her to be able to use that Kegel muscle for both contracting and releasing, contracting and releasing. And she had to learn to relax that pelvic floor to be able to enjoy intercourse with her partner. They later got married, so I can now say that her husband. Sexual trauma. There are cases where the female has experienced some kind of sexual trauma, often early in life, and sexual traumas don't go away, unfortunately. They stay with us. And sometimes it's really in that phase, excuse me, when partners are experiencing additional medical and health challenges to their sex life that we discover that there was sexual abuse during childhood or during the teen years, or there had been sexual molestation. How long it's been, etc., is very important. And the nature of it, whether or not the perpetrator is still in their life, is very important to helping them move through that kind of trauma. And that trauma can very often cause vaginismus to one degree or the other. Classical vaginismus is rooted in sexual molestation and sexual abuse in childhood. That's a classic case. Yes. Sometimes the female was not penetrated during that abuse, but just a touch and the nearness and certain things become triggers for some degree of vaginismus where there may not be a possibility for full penetration. So we want to look into that when we're looking into the issues that surround getting older as well, if the person presents with any degree of vaginismus. The first question that's going to be on my mind is, was there sexual trauma? Yeah, there are a number of therapeutic approaches to dealing with sexual trauma, but certainly we have to deal with the physical, giving them physical exercises to deal with not shutting down the walls of the vagina, and we have to give them psychosexual, psychological, behavioral therapeutic approaches that assist them in releasing the trauma and going through it. It's not an easy thing, and it does take a long time, but it is certainly possible for persons who have been abused and who are experiencing vaginismus to engage after time in good sexual intercourse and good sexual activity outside of intercourse. Because as I say, sometimes it's not the penetration. Sometimes a mere touch in a particular area can cause that clenching. And that, of course, is going to lead to dyspareunia as well. So dyspareunia has many, many rooted causes, not just physiological, not just a dryness, but also there are psychological issues related to it. Yeah? Okay. I certainly support integrative practice. I certainly support the working of multiple persons in the treatment of the client. You know, in psychology, we don't say patient, we say client. I think it's important to have a full history. I think it's important for us to consult with the gynecologist, or as in the case of men, the urologist. I think it's important for us to be able to speak to GPs if that's where people have come in, and to understand what presented in the clinical setting, in the medical setting, so that we can assist the client. We also need to think about the masturbatory practices that a person may have but has not discussed with their GP or their OBYGN. Very often that's missing from the sexual history, and sexual history is taken outside of a sex therapy's office may not include the first awakening of the person to sexuality. It may begin with first sexual intercourse, and that's not the first sexual history that we want as sex therapists. We want to know, when did you become aware of yourself as a sexual person, and what was the cause? Was it someone interfering with a person as a child? Was it something that was age appropriate? We need to know that to know where to go and where to examine for bringing us into this healthy relationship with sexuality. In therapy, we're going to be asking ourselves the question, is it lifelong, which means a generalized difficulty? Is it partner specific? It only happens with a certain partner. We want to know what characteristics of that partner cause this repudiation of sex, whether it is anorgasmia, dyspareunia, low sexual desire, etc. Right? And we want to address those psychic conflicts that exist with the person's internal structure around sexuality, and resolve the relationship, communication issues. People speak about communication all the time when they come into therapy. They say, oh, the problem in this relationship is communication. That's a big C. It's a very important C. But it's not as simple as communication. It could be conflict styles that differ. It could be resentment that's been there in the relationship for some time. And resentment is a main cause for men in particular to lose their libido, lose their sexual response in a partner specific way. Yes? So they may function elsewhere, but may not function within the main relationship. And that's something to look at. We want to assess and treat the sexual desire disorders by asking ourselves, has this person always experienced this? Is there a discrepancy between their sexual desire and that of their partners? And is it that this discrepancy, one wants a lot, one wants a little, one wants it this way, one wants it the other way, is that discrepancy something that has gone hidden in the relationship up until they come into your office? Has one partner given up on being sexually active with the other and really doesn't want to be bothered anymore? We want to know why. Yes? Because that's the only way we can get to the point of saying, well, is this to be a full relationship? And how do you imagine that you will go forward sexually? What would you like to do in this instance if you're no longer interested? Does the other partner have liberty to go outside the relationship? Because in many instances, that's what's going to happen if we don't address the sexual problems in the relationship. Okay, and then I often tell clients that I want to make them a sexpert. If you're having sexual performance difficulties, if you're having female sexual disorder difficulties, at the end of the therapeutic protocol, I really want you to be a sexpert. I want you to be an expert on your own sexuality. I'm not saying that you will know everything there is to know about sex, but I certainly would like for you to know what your sexual response cycle looks like, why you're not functioning the way you'd like to function, and how you can function better. Because nobody knows your body better than you. Yeah? So we need to deal with those mental, emotional, physical simulation issues and help people to train themselves out of the dysfunction, if you like. Okay. And I'll stop there because the question and answers are always more interesting than the presentation. Thank you.
Thank you so much, Professor Carpenter. That was a very comprehensive and enlightening presentation. It took us back as clinicians. When we say sexual history, as you say, we have certain questions that we ask, but there is so much more that we don't explore that your talk has shown us that we need to be aware of. And oftentimes, persons may not come and complain about the problem, but it's something that if we build the trust and the rapport with the patient, then they are willing to share with us. And then the importance of the integrative practice, the fact that as clinicians, we are as family physicians, we don't have to do it all ourselves, that there are persons who have expertise such as you have, who we can work with for the benefit of our patients. So I thank you very much for that presentation. And I am going to ask those who have questions for Professor Carpenter to put them in the Q&A. At the end of the session, we will look at those, but I would encourage all our presenters, Dr. Phillips, Dr. Minor, Dr. Carpenter, to go ahead and look at the questions so that you can begin to answer some of them in the Q&A section. Please put your questions in the Q&A and not the chat. There were a few in the chat, but they have been answered as well. And there are some answered questions in the Q&A section. Professor Toller-Reed has really helped us a lot, and he has really put some answers there. So in between, you can take a chance to look at some of those answers that he has put in as well. But we do need to press on. We are a little behind time. What we have now is another presentation by our sponsor, and then our last presenter, Dr. Frankson, will come to us. So if I could ask Mediplex,
I said due to the time, they've done their presentation already. They'll allow us to go right to the next presenter.
Thank you very much, and we do appreciate that, and to be honest, we are so familiar with so many of Medimplex's products.
Yes.
And we do appreciate their ongoing support of the Caribbean College of Family Physicians. So, Dr. Frankson, you've been with us from morning, I know, and we are very anxious to hear what you are going to say and share with us. But let me tell you a little bit about Dr. Morton Anthony Frankson. I know him as Tony. He's a Jamaican general practitioner and public health physician with expertise in epidemiology and biostatistics. He serves at Northern Caribbean University as campus physician and director of research and statistics, where he also chairs the Institutional Review Board. He chairs the National Merit Committee of the Bureau of Standards Jamaica, and he is a past president of the Bioethics Society of the English-speaking Caribbean. He retired from the University of the West Indies in August 2023 after more than 14 years with the School of Clinical Medicine and Research in the Nassau, Bahamas. There he mentored family medicine trainees through their research requirements and served the Bahamas Association of Primary Care Physicians for about a decade as treasurer and later as associate treasurer. He is a long-standing member of the Caribbean College of Family Physicians, and he remains committed to advancing bioethics, research quality, and primary care across the region. Certainly, when we used to come to Bahamas for exams, Dr. Frankson was an integral part of our research presentations. So at this point, I would like to welcome Dr. Frankson to speak on the pros and cons of hormone replacement therapy in women and the ethics of hormone replacement therapy, balancing the benefits and risks. Dr. Frankson.
Hello, everyone. Thank you very much. I'm going to log out of the site and log on to my desktop because I need to share this. I'm so sorry. Running a little behind.
It's okay. Let me see if I can help on my end for you to log in, Doc. 1 second.
That as we wait, I encourage you all to go to the answer tab. Professor Tollery has put in a number of informative tidbits there. So as we wait for Dr. Frankson to start, you can look at one or two of those. Dr. Frankson is with us now. He just needs to share his screen. And then go to his presentation. Is your presentation open on your computer, Dr. Frankson?
Sorry.
Doc, you don't need to go into Zoom, right? We need you to go to the PowerPoint.
You could speak, let us see if we hear you.
Yeah, the device sounds like it's corrupted. Is it a built-in microphone or it's a microphone that you have plugged in?
Last time.
Sorry, let's see if we can find your PowerPoint. Why is it not opening? Is this the presentation? Yeah? This is it?
Sure.
If Sam has access to the presentation, he could do the slides and you could use the other device where if you think it's better.
Yeah, Doc, do me a favor. Can you log in on your phone as well? You should be able to log in on both devices. Yeah, it's not good. I hear that you're asking me if I'm hearing you, but it's something. If you could just log in with the phone, what I'll do is walk you through using your phone as the microphone, and I'll turn off this one, and then we'll have a good presentation. Gonna ask you to mute as well your right, so that we don't get an echo. Once you're logged in, I'll fix the audio. And while everybody's waiting on us, we thank you so much for spending the day with us at today's Women's Health webinar. Please note the instructions for CMEs. Get in touch with the secretariat at the Caribbean College of Family Physicians Jamaica chapter. And once the payments are made for CMEs, it will be arranged for the certificates to be emailed to you. Doc, is it logging you in or is it giving you a problem? Dr. Morton?
I'm hearing.
Yeah, Dr. Morton, I mean, can you hear? Or can you get in on your other device? Pardon? What happens when you try to get in on the device, Doc? Not hearing you, unfortunately. Yeah, yeah, Doc. I've seen that you're logged in on this one now. Is it that it's not allowing you to log in on both devices?
Your system is not allowing me to log in on to log in on both devices.
No, man, like the permissions are there. 1 second. 1 second, 1 second, 1 second, 1 second, 1 second, 1 second. Even 5 years after COVID, we can still be surprised by technology.
Yes, technology is our friend, but sometimes it can challenge us.
It can challenge us, but where there's a will, there's a way. And I'm not Will, but we'll find a way.
And I do want to remind our family physicians who are online of the presentation about the Caribbean College of Family Physicians, which was shared earlier, and to encourage those of you who are not active members to become active members, because as you saw in the presentation, there are advantages to being a member over and above the CME activities that do occur. There is the
Dr. Martin, 1 second for me. I just want to make sure. 1 second.
sure.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care. The Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean.
Dr. Franson, I just sent you another email with a link, but I'll ask you to do. You're already logged in on your phone. If you could navigate to your email, it's the Gmail that we have on file. Let me know if you're seeing that email, and then you'll be able to use your PC to log in. We'll use your phone for the audio, and we'll allow you to share the screen from that second link. Can you let me know if you're seeing it, please?
Okay, looking for it now.
Sam, maybe I could go ahead and take the question and answers in the meantime, in the interest of time.
Definitely, in the interest of time, sure. Mm-hmm.
Let me go back to the Q&A, and some of the questions have been answered, but there are...
Its work empowers physicians.
There are some that I would like to... There is an interesting one that actually Professor Marshall Toller-Reed had answered. I think, is Prof Toller-Reed still with us?
I think Prof might be also seeing where we have the presentation up.
All right, so I think you're ready. So we'll hold this for later.
Sure. So once we go full screen, Doc, you're good to go.
Okay, not going full. Not going full screen, but
yes.
Yeah, man, there it is.
There it is. Oh yeah, certainly decided to do it.
So over to you now, Dr. Franson.
Okay.
Sam will help.
Thank you for the introduction, and thank you, Sam, for your ingenuity.
No problem, Doc. You can just look at the screen at your presentation. You don't have to forget that the phone is even on, and just enjoy your presentation. We look forward to it.
You're a good therapist. Okay, and greetings to everyone, including our moderator, my longtime colleague from medical school days. And I would like to just just let you know that I have no special declarations to make with regards to any conflicts of interest. And going to look at some issues related to hormone replacement therapy, and with an ethical slant to it, putting on our ethics lenses this afternoon. I'm going to assume that you know a lot about ethics already, and that we'll just use that to learn what is out there for HRT, and then make our ethical assessments as we go along. So that's my little agenda there. And let's start off with some basic physiology. When it comes to menopause, it's a natural transitional occurrence, and it's to be navigated with grace and ease. In many cases, that is how it is. The body, by the time you are 20 weeks in gestation, has the maximum number of eggs and fertility, and the promise from there on starts to decline once there is each menstrual cycle. Inhibin B, it negatively inhibits the anterior pituitary follicular stimulating hormone production and the modulation of estradiol levels early in any menstrual cycle. There is a concomitant increased aromatization from testosterone and other circulating androgen hormones that was going along as well, all helping to keep the time clock ticking. And however, is associated with an increased risk of worsening or contracting of medical conditions once we reach the stage where we have just a few eggs left. And in fact, when menopause ceases. So there is a pathophysiological aspect to it as well, where decreasing inhibin is accompanied with progesterone decreasing during the second part of the menstrual cycle. Continuously luteinizing hormone stimulates the production of androgens as well. There's depletion of all follicles as they leave the ovaries and no longer able to respond to even very elevated follicular stimulating hormone levels, and the estradiol production decreases. With that, we get symptoms of withdrawal from that bath of protective hormonal mixture. And then we have symptoms that manifest with those changes at the metabolic level. The symptoms are largely due to persistently elevated estradiol levels plus low progesterone levels. They include, in the early stages, periods that are heavier and closer together, some women report, where some women have a completely as uneventful as you might imagine, those lucky few. And there's endometrial hyperplasia, and that is examined. Enlarged fibroids may be seen, and worsening of endometriosis may also occur. The last 6 months of menopause, what we have is estradiol levels, and it's falling rapidly prior to the final menopausal period. And this can occur even up to, say, 10 years before the final period is experienced by the woman. And with it, the effects are able to be seen in the central nervous system, among other places. There's increased vasomotor symptoms and at times increased cardiovascular and all-cause mortality associated with those who tend to have more of these symptoms in the late phase, late onset vasomotor symptom manifestations. And in general, there's instability of the central nervous system, increased serotonin levels, decreased norepinephrine levels, narrowing of the neural zone of the hypothalamus, and you can get hot flashes, night sweating, sleep disturbances, depression, daytime fatigue, and those who feel it know that there are more of those things as well. And those who are married to those who feel it also have secondhand experiences and find that the word husband really means house band, where you have to really offer tender, loving support as a strong band around her, supporting her, or else that becomes something that is one less thing in a good quality of life experience and one worsening of quality of life. There are some reasons for increased, for cardiovascular increase in menopausal transition. The decreased estradiol levels causes increased low-density lipoprotein levels and total cholesterol, decreased high-density lipoprotein levels. There's decreased prostacyclin levels, decrease in nitric oxide synthase, Decreased conversion of angiotensin converting enzymes to angiotensin 2, and decreased endothelin, estrogen, estradiol decrease also can have C-reactive protein levels being at the levels where they can damage the arteries. And what we see on the right hand is the increased risk of atherosclerosis that manifests with that underlying pathological base. More vasoconstriction, easier vasoconstriction. Therefore, you get your hot and your cold, and you also get in your cardiovascular efficiency being challenged. Endothelial dysfunction increases the risk of things that may lead to things like a myocardial infarction. So you will find that the myocardial infarction rate before menopause was quite protective, but as it goes through this and then even after menopause, it starts to equate with that of a man, and sometimes in women who carry excess, who are obese, etc., it may supersede that risk of a man. And all of this further increases risk of atherosclerosis. All of these 4 things are to the left. And it's progressive, in other words. Decreases in LDL oxidation also occurs, which is not good. Increased likelihood of insulin sensitive resistance and adrenal dysfunction and cortisol imbalance, among other things. And moving on, there's also other risks, that things that can be increased. Some of them were mentioned in earlier presentations. In passing, estradiol present at this phase decreases bone resorption by lowering the sensitivity and the parathyroid hormones and increasing calcitonin. So what we're going to have here is osteopenia, more easily developing. Osteoporosis, the same thing. In the gut, in this phase, tries to increase the calcium absorption. And with the loss of the estrogen, however, that is undercut. There's also the gut decrease, the decrease of loss of calcium to the kidneys, and this is also undercut in that way as well. As if that were not enough, there is increased tumor necrosis factor alpha, interleukin-4 cytokines, and loss of yes. And yeah, and with loss of estrogen, all increasing osteoclastic activity and bone turnover. Progesterone and testosterone both improve bone formation, but increased cortisol blocks these protective effects, leading to increased bone loss at menopause. Cognitive change declines that are usually are too often seen, and so the impact is really on the prefrontal cortex, hippocampus, and still other risks. Increases that in menopausal transition. Right? Estradiol helps collagen synthesis, glycogen production in vaginal mucosa, increased activity of lactobacillus to survive or thrive, maintaining of a low pH environment there, plus healthier vaginal microbiome. But as that is altered, what we're seeing is vaginal dryness, incontinence with weakened pelvic support structures, especially after childbearing, and chronic constipation or obesity, atrophy in those areas and other places as well. Increased irritation of the vagina is more possible, and potential difficulty, painful sex, or otherwise known as dyspareunia. And the situation demands, it would seem, that we do things about it, but even in trying to do that, controversies exist. And these controversies are some of them are listed right here on the screen here as in the form of questions in some cases. Should all women be given replacement of estradiol, given its vast benefits during their reproductive years? The principles of ethics say that we should actually try to bring benefit to situations that we are interfacing with as we have our doctor-patient relationship. And at the same time, to balance that, as the other side of the coin, it says, as much as possible, that's my alteration of the phrase, do no harm. The actual phrase is first, do no harm. In other words, it's almost impossible to do absolutely no harm in anything in medicine. But we will minimize the harm as much as possible as we do a risk-benefit ratio analysis, whether informally or formally. And we come to see whether the benefits outweigh the risks. We will get to some of that as we go along. There is such a thing as the timing hypothesis, the first 10 years of the last menses versus later on, are the time periods that are the two dichotomies there. The question here is the timing hypothesis credible regarding retarding plaque formation versus plaque erosion or rupture and acute coronary event occurrence? And research is showing us that it seems like intervention earlier on really is providing credible evidence to retard plaque formation, and it is intervention that is too late in that hypothesis windows that more so has now already the horse going through the gate. There's already plaque formation before the intervention actually was instituted. And therefore, what is more likely to happen is plaque erosion and or rupture and acute coronary events occurrence. So that is helping, evidence is helping to clear that up. We do want to include justice, equal access to treatment in that sense. But in real life, many times people do not access the healthcare system early enough for these particular complaints. And what you're faced with sometimes is the woman who is not in the favored part of the time hypothesis. They're rather in the latter part rather than the first 10 years of the last menses. These are some of the issues that are being weighed and moving along. Can valid and pragmatic conclusions be arrived at despite there being heterogeneity or disparity in the hormones used in research of menopause issues? And most of the hormones that we use so far that have been researched at least have been conjugated equine estrogens. So really, we have here challenges that we have to face, and these have to be weighed. Does using estradiol and progesterone, not synthetic progestin, have better safety profiles? And I'm a public health physician, but I will chance it to say that the research is showing that using the let me go to the next one. Yeah, using those estradiol, etc., seems in many cases to make the treatment be a simpler thing to negotiate with our patients. Let's talk a little bit about assessing present risk. Early hormone replacement therapy treatment in the perimenopausal stages seems more likely to be beneficial regarding long-term health than postmenopausal hormone replacement interventions. I smile because I remember years ago when I was a young physician, how we were gung-ho to treat women with hormone replacement therapy. Then the early studies that had bad news came about the increased risk of endometrial cancer, and quickly it was shut down. But this is the nature of knowledge when it is handled by professionals. There were those who persisted and created these other ways of thinking philosophically about it. And now we are at the stage where we are weighing it and seeing whether we have a right and a duty of care to offer women hormone replacement therapy, and at what stage of the time window hypothesis. It's very rewarding to have practiced medicine for about 50 years and to see the various changes that have happened as we go along. And so it really is important to know not only ethics and philosophy, but also to know good research principles and good research philosophy as well. That shows that nothing is really totally abandoned. It is something showing a negative effect in research. One of the duties that we have as professionals and as research scientists in the area is to ask further questions and ask them in more nuanced ways as we get better understandings of the physiology and indeed the pathophysiology of these things. Several physicians are now adopting a specialty called, as family medicine physicians may want to go on, and some just go straight on into it, called functional medicine. I'm not here to describe it to you today, but I learned something that is useful from their school. And the Institute of Functional Medicine uses a stoplight analogy, red, yellow, and green, when thinking about giving hormone replacement therapy. And being an equal opportunity researcher, as I have to be as a scientist, a medical scientist, I listen to all camps. And I would encourage you to listen to all camps as well and prove all things, you know? And one of the things that they have as a recommendation is the red, yellow, and green spotlight analogy. Red is when you have conditions relieved with treatment other than HRT, and that's your classic risk levels and contraindications to hormone replacement therapy. For example, undiagnosed genital bleeding, a history of or current breast cancer, history of or current thrombotic disease, active stroke or myocardial infarction, known liver impairment, suspected thromboembolic disease. These are some of the things that may want you to want, first of all, to relieve those particular conditions if it's possible. And then only in those who it was possible to relieve do you proceed if the patient still desires and consents to hormone replacement therapy. Then there's the yellow light, where the conditions really are more amenable to lifestyle changes that really can benefit them. And once they are adherent to the lifestyle changes, then if you see that it is really alleviating those particular risk factors, then proceed to hormone replacement therapy. And what am I thinking here? Underlying conditions predisposing to breast cancer, for example, increased BMI, abnormal estrogen metabolism, poor methylation, dense breasts on mammography, elevated leptins, genetic markers for either estrogen metabolism defects or cancer. And of course, the green one is no commentary. They're free of all of those. And it's just based upon now the other tenet in ethics, which is respect for persons' autonomy, which means consenting them in private, confidential settings, and making sure that it is informed consent. At this stage in the presentation, I hope you are a little you find it a little remarkable how complex this process of this changing, this transition from a premenopausal to a perimenopausal through to postmenopausal stage in a woman's life is. It really is a complex thing. And to really be a master at giving sufficient informed consent is paramount. When I teach this medical students what informed consent is, I tell them what I mean is we informed the patients in very reasonable ways, commensurate with their level of comprehension. And then the word doctor means teacher. So you give the patient an exam and ask the patient to tell you what they understand from what you have informed them about. And if they pass the exam, then you proceed to accepting the consent. Then it is, and only then, that the consent is really, truly respectful of what the Nuremberg Code, etc., the Belmont Report, etc., are striving at and still uphold. If the person is struggling and not able to comprehend, then the duty is upon us to find ways to communicate this information rather than taking over the person's life and say, and especially be aware of the patient who says, "You know best, doctor." That person has just set you up, and if anything goes wrong, will turn around and be just as zealously going after you with a lawsuit. So make sure that we're diligent about this business of informed consenting. The last point there says assessing breast cancer risk involves many steps, and some of them include, and that's just, I single that out as one of the things that are high for us to be careful about, and not pushing for hormone replacement therapy if there is if there's a high risk for breast cancer. So good history taking, looking for family history, etc. We're available, testing for things like BRCA genes, mutations, and other mutations. Remembering that really it's only 20% of what causes breast cancer that we really seem to have a handle on the etiology of. That means 80% of breast cancers, we still can't explain them. But a history of it is helpful, including estrogen metabolism issues. There are now very sophisticated tests for those, the P54 single SNPs and your 2-OH estrone metabolites, 16-OH, 4-OH versions, and estrone metabolites. All of those things are really things that we should be working with, not so much as a primary care doctor, but in close collaboration with somebody whose expertise is in this domain. Visceral adiposity levels, from the first presentation today right through to several others, that was underscored as a problem. And until that is altered by lifestyles, then it can be considered a risk for breast cancer and also a contraindication for hormone replacement therapy. Insulin dysregulation, stress degrees, and the cortisol levels. Very stressed people with wacky cortisol levels, out of bounds, etc., are really and courting the inviting of oncogenesis, as well as not just canceling themselves out as good candidates for hormone replacement therapy. And of course, we mentioned mammography and leptin levels already. So, what are some of the approaches that we can use to interface with people before we actually move into hormone replacement therapy? lifestyle, I mentioned earlier, biochemical interventions and botanicals are now with more and more complementary and alternative medicine becoming more and more in vogue and part of our armamentarium for some of our practitioners. And there are traditional interventions that we have had from various cultures, be they Chinese or Middle Eastern or in our own cultures as well. And all of these require ethical considerations. So let's deal with lifestyle first. It's always, I would recommend, and most people in the area would recommend, to be the first intervention regarding symptom relief. Because of two reasons. One, in many cases it works. And two, too often, people's lifestyles really need to be modified with total lifestyle change, TLC, if you want to remember it in friendly terms. And you really want to give a strong emphasis on people using only that rather than going to hormone replacement therapy if they're having minimal associated risks in most cases. If we're going down the lifestyle route, we should do it holistically, treating their diets, including vegetables and other components of food, fats, and proteins, etc. And in a way that we're talking about increasing their servings of vegetables daily to maybe 9 to 12 servings. Healthy fat consumptions, have a good avocado, pears, nuts, seeds, etc. In other words, sources that are likely to have a high ratio of monounsaturated to saturated fats. All of those things have been shown to modify not only preventing oncogenesis, but and they've been encouraging in also managing the responsiveness of estrogen receptors, etc., and therefore many of the vasomotor symptoms that are manifest are coming through when there is menopause and perimenopausal experiences. The strong recommendation these days, lifestyle-wise and ethically, we should promote what is best, plant-based protein sources. And I use plant-based because you can do that even as a meat eater, where your majority of your protein is plant-based, but you may also add some animal proteins, especially those that are lesser in body fat composition. It's interesting that, you know, a free-range chicken has 2.5% body fat, and a chicken grown with modern industrial techniques has 25-point-something% body fat. I would encourage a woman who is having challenges in this area to encourage her husband and herself to try their hands, if they love chickens, at less of those other sources and more of the home free-range sources of chickens and eggs too, etc. But if you want to go vegetarian, there is so much good evidence for that. And if you go for including meats, pastured animals with less hormones and pesticides and antibiotics seems to be the ethical thing to do. And there is so much good research now that shows in so many ways that limiting our sources of added sugar helps our body's sugar intake to be within a range of a favorable glycemic index, that we should go in that direction, and we should encourage women experiencing these things to, or you are considering for hormone replacement therapy, to try these things in really zealous ways, which means they may need coaches, and you may need to have something that we don't have yet here in the Caribbean, but they have in the United States. There's a specialty in the United States called preventive medicine. We would have said preventative medicine, but they say preventive medicine. And a subspecialty in it called intensive lifestyle intervention. These are things to be considered very, very favorably. I remember at a visit years ago to the Caribbean Health Research Council, one of its meetings, I think it was in the Turks and Caicos Islands, a team from Barbados, from the Chronic Diseases Center, the Research Center, were the first ones in the Caribbean to show that Caribbean people too can get the same results that Dean Ornish had over there in California of reversing atherosclerosis, reversing many, many things, even reversing the pathological effects or manifestations of diabetes and prediabetes. And so we really are without excuse now to be encouraging people to elevate their lifestyle to that of a really healthy, wellness-oriented lifestyle. Of course, that includes your fruits as well, but not to the point where you're defeating the whole business of controlling your sugar intake so that you can have more complex carbohydrates. And with it, you can have, with your grains and so on, being more of the whole food, etc., rather than the processed ones, etc., and rather than smoothies with the lovely fiber left out and thrown away, and only the juice of the smoothie, having the really healthy smoothies, etc., and on occasion, because they too are of high glycemic index, and so on. And of course, the last point on this slide says, how can we say lifestyle without exercise, sleep, meditation, healthy environment exposure? And by that, I mean physical environment, social environment, mental environment, and spiritual environment. Our choices really do matter. And these are things we should be offering before advancing to hormone replacement therapy. I think that would be the more ethical approach. Now, just a word on the biochemical and traditional interventions, botanical interventions. Some women will go for that, and their choices and their preferences, it's ethical to have that as the first consideration. I need to say something else in passing as well. When we ask people to have informed consent, and we go through the process I described, if someone declines, if you embark on a process of not just accepting that declension, but attempting some health promotion and health education to go to respectful and enlightening persuasion, that is appropriate. That is not overriding a person's decision to decline. We certainly know that in research. In survey research, we have rules. When we survey, for example, somebody, we call them on the telephone or face-to-face or whatever, we have rules, and sometimes we are barefaced enough to include them in our proposals, and I always see how they usually mesmerize the ethics committees when we tell them that this topic is so important that we have to hear that person declining up to 20 times before we say that, no, you don't want to do my survey. You might well have experienced that, because those telemarketers are extremely persistent, and they will find ways to find all your numbers, and they have limits on that will govern them as well. I think sometimes we give up too easily when we know what we think persons should be hearing. They haven't heard it enough, and they have declined too quickly. To persuade somebody is good duty of care, to responsibly persuade people. But maybe it would be a good thing to set limits that your group with which you practice, your hospital, your institution, etc., permit you to persuade. Maybe 5 attempts, 4 attempts, 3 attempts, etc., but certainly not 1 attempt or 2 attempts. because people are at a disadvantage and they are at a more vulnerable level of power, and they have their own issues sometimes in the doctor-patient encounter that sometimes may be confounding their consenting process. So it is quite ethical to have an agreed on number of times to try to persuade a person and to proceed with that. And when that number is exceeded, then you call that a solid no, I decline. If we don't do that in research, we will get a lot of the most important participants being left out, and our study sample size will be very biased. I know that research is not the same as patient care, and that for research, we are more looking at the larger, broader effects of the community and representativeness and generalizability and so forth. Whereas in patient care, it is that reverence for that one-to-one relationship, a much more therapeutic relationship. But there's like a Venn diagram. There is some overlap in the two camps. And this is one area where I think there's that shared intersection that when the two Euler circles overlap from your days of algebra and so forth. So those are some of the ethical considerations I would put on that. And the biochemical approaches, they are to be, I've listed a few here. Botanicals that some people might want to try out, try out because our most vulnerable receptors in our bodies are estrogen 2 or E2 receptors. And some plant extracts actually bind nicely to those E2 receptors. And I would just say they include Serbian rhubarb extract. However, I must ask that you have caution with those women who have a history of breast cancer, as that also that is a promoter in such cases. Some extracts are shown to be as effective as low-dose estrogen treatment in clinical trials. Black cohosh, Actia racemose. Multiple effects have been shown with biochemical studies on the estrogen receptor modulation and serotonergic action, suppressing vasomotor symptoms, similar to our SRIs. Some of our studies some clinical trials have shown. Sage, Salvia officinalis, seems to be good. Some people testify for hot flashes and night sweating, and maybe the breaking point where people say, no, I don't need a hormone replacement therapy anymore. I'm having such a wonderful time imbibing this. Donkey, Angelica sinensis, one of those Chinese herbs. There are those who have found benefits there of a similar nature as well. And red clover, Trifolium pratense, as phytoestrogens binding closer to the estrogen receptors, and we can use as add-on herbs. Ethically, there is nothing wrong with that, and we would only ask that you be honest and that you seek out the literature and inform your patients based upon the evidence. That's what I've tried to do today in passing, and I didn't major in that because that was not the theme of my talk. But there are other traditional methods that ethically are okay too. Progressive relaxation of muscles and muscle relaxation, breath work. There's a lot of work that has been done by some researchers at Stanford University that teaches us that we breathe too often through our mouths. We are the only animals that default too easily to breathing through our mouths when we are a little bit exhausted. Most animals, they point to in nature, breathe through their nostrils. And what the Stanford University investigators found is that the erectile tissue in your nose actually is one of the one of the most wonderful areas in producing nitric oxide, which I didn't know before, and that nitric oxide has many effects, which we all knew, of course, and that they have wonderful cardiovascular effects, as well as, it seems, some effects on some of the vasomotor symptoms that we have here. Altered sympathetic tone, reduced sympathoadrenal responses, increased parasympathetic tone are all things that progressive relaxation and muscle and breath work seems to do. And I'm not even talking about yoga, but there are papers that show that it has some effects in that way as well. And there are other complementary and alternative medicine approaches as well. Manipulations have been shown to show significant reductions in vasomotor symptoms with low force osteopathic manipulative techniques. In research, the researchers, however, say that they see the effects, but they're not sure of the mechanism. Massage body work, multiple sessions of massage therapy seems to improve vasomotor symptoms and even more so improve anxiety and insomnia. Very interesting. It's not good for people to be alone, and it's wonderful when those who are with people interact with them, even physically, beneficially as well, with things like proper touch, proper manipulation, proper massage, etc. Mind-body interventions are several, for meditation, etc., and they seem to work after 8 to 12 weeks, some studies show. So I find this all some of the things that we should be offering before we go to hormone replacement therapy. Hormone replacement therapy itself, hands down, gives you the fastest way to alleviate motor symptoms. Acetaminophen, much faster to relieve headaches than massaging of the temples, etc., and some neck exercises. And but I have been amazed that students who I come here with who say they don't want medications, if they could ask the nurse to just give them a massage and their headaches go away. So the chemicals such as ibuprofen and acetaminophen, etc., put them toe to toe, they always reduce things faster. But is that the only way, or the most common way we should be going? Keep an open mind. However, there are those headaches that the argument is over. Only the acetaminophen helped, or if it's a migraine, you have had many lectures in the past through this very portal here, this very same organization on migraine, etc., with wonderful people like Dr. Ali and so forth. So many of our wonderful neurologists who have visited with us, and they have given us a plethora of wonderful medications that can be useful for some of those things like headaches, etc. Well, the same thing for hormone replacement therapy. If these other things your person is trying them, or the person is not adhering to the lifestyle things, but in other ways qualify for hormone replacement therapy, then this is the one to consider. The time has come for it. And the fastest way to relieve symptoms, it is. But the form needs to be decided early with each patient. Likewise, the dose too must be decided on, because different patients have different goals. Some just want relief of vasomotor symptoms. Others have been impressed by the cardiovascular preventative effects, and that is their goal. So we have to know who and we're dealing with and what it is that we are really trying to achieve as we team up with our patients supportively. So agreement exists that firstly, the lowest dose and the shortest duration must be attempted. I think that is ethical because, one of the goals of medicine is to relieve symptoms. a very laudable goal, long tradition of that. And this, of course, the best way to relieve symptoms is to prevent them in the first place. But there are levels of prevention, and one of those include secondary prevention, which embraces cure, and tertiary prevention, which embraces control, and so forth. And so it fits right in there, where we would like to relieve the symptoms with the lowest dose possible, with the shortest duration, because everything that we give people have a potential for some side effects. And with an issue like this, that is the arena in which it lies, that of research, especially translational research, I should say, so much more is still to be learned. And so we proceed with the encouraging results, but we proceed wisely, cautiously wherever we can. There are the bioidenticals and the non-bioidenticals, or new to nature, and the new to nature and non-biological compounds. That's what I'm calling the non-bioidenticals. And the bioidenticals are proving to have a safer safety profile. So there is your various principles of ethics, checking off those marks, and a variety of them are commercially available. Estrogen is the only hormone for which there is no FDA-approved version. And that is because it has several, it's very complicated to produce, and what has been done so far has not proven to be very encouraging when it relates risk to benefits. So we very carefully proceed with what we do. And if you add testosterone, it does seem to have some effect in some ways, but be very careful about how we add a compound that has testosterone in it. So consider the form and the root, considering that, and the root is vital. The transdermal may be the safest of all, safer certainly than oral, because when we give it oral, the process that it goes through in the gut, etc., liver, etc., makes byproducts that seem to increase the cardiovascular risk for some of these hormone replacement therapies. So the transdermal progesterone is a different story. It does not provide adequate protection of the uterus. So use oral routes here instead. If the compound, the tablet has, or the medication has progesterone in it, and if it is given with estrogen. Beware, though, that oral progesterone preparations have as a base, a carrier base, peanut oil. Need I say anymore? There are those who are allergic to that. So taking a good history should pay attention to unearthing that piece of information about an allergy history as well. Sublingual or buccal seems closer in safety to the transdermal estrogens. That too is still being researched as far as my latest literature search found. Injectable estrogen plus testosterone pellets are not FDA approved because they're unpredictable, have fluctuating estrogen serum levels, and are inappropriate high levels of testosterone that can last for months. And those are not desirable. So beneficence and non-maleficence must be considered here with prudence. The dosing should be to simply reduce the vasomotor symptoms. So it should be the lowest possible and for the shortest duration that you can see it proving to be effective. Giving a respite to the person and allowing the person, therefore, to now be able to even step up or recommit themselves to lifestyle approaches integrated with whatever has been done with hormone replacement therapy. Like we do for hypertension, etc., we say for pre-hypertension and for early hypertension, lifestyle, and of stage 1, and so then we add other things, but we never, in any stage of hypertension, say stop the lifestyle. And this must be true also for hormone replacement therapy. You still continue the lifestyle intervention while we're doing this therapy. So monitor closely, especially for women using hormone replacement therapy to improve health markers like excellent cardiovascular health. Cognitive decline is we want to be stemming it or even reversing it if possible. Addressing osteoporosis as long as thought possible, up to maybe even 10 years, huh? But that's what the research is telling us at this point. So this is my final slide. I would like to say that there are 2 approaches that I hinted at from the ethics point of view, and one is a case-by-case approach, which is the one I mostly argued along the lines of with my presentation. But I must remind us that we have to also consider the principles-based approach, because when we adopt what to do with this situation, we are going to be the ones who the government, etc., and other deciding bodies will look to for guidance with policy and public health considerations. And that gets pretty complicated because the public health side of ethics is one that is in some ways surprisingly different from the bedside approach to ethics. For example, there are times when the greater good makes the community's interest trump the individual's interest. I don't think hormone replacement therapy will get to that stage, however, where it will become something that is strongly recommended by the government. Well, if it does, then we have to fall in that arena. I can see some of you smiling now, and some of you with your raised eyebrows, but that's just me still thinking about this topic. And that's what I hope I got through with you today. I got us to think and to wrestle with this, because the story on this is not finished. And part of what needs to happen to manage this whole thing so that our patients get the best is for us to constantly look at it through ethical eyes. I thank you. God bless you. High five to you all.
Dr. Frankson, that was such an enthralling and thought-provoking presentation. And I understand we owe you a special, special thanks because you came on board late in the day to fill a void. And wow, I can't believe that what you presented was prepared in that short space of time. It was really enthralling. You took us through the ethical and evidence-based analysis of treatment options, looking at the choices in a very balanced, ethical way. What the interesting point I thought you brought out was something I hadn't thought about before, the difference between persuasion and coercion, because we're always told we're not to coerce our patient. But persuasion is a different thing, because the first time somebody declines something, it may be because of lack of knowledge. And if we respectfully say to them, okay, I hear that you don't want to do that, but would you mind if I just share a little more information about it so you can think about it? Without being disrespectful, without saying to them, no, what you are saying, it doesn't make sense. You try and share more information and give them the opportunity to really maybe come to a different conclusion after that. So I thought that particular item where you spoke about persuasion was very, very, very important, because often the patient says, no, I will just leave it at that and we don't go any further. So thank you, thank you, thank you. Now we know that time is upon us, and I think the other presenters have taken the time to answer their questions in the Q&A section. So I'd ask participants, especially those who ask questions, to look there. But there are a few questions for you, Dr. Frankson, that I want to ask that you address. This is not necessarily for you alone, but the question is HRT available in Jamaica, that is patches, estradiol, vaginal creams? That would be the first question.
I would have to refer that to
yes,
a gynecologist. I am very biased. I am the doctor for the university, and you also work with the university, and most of our clients are not candidates for HRT. They're too young.
Right. But I do believe, I do believe.
I don't know if you have the answer, but if you do, please say
No,
it. Because I am not experienced in that.
I do believe that some of these things are available, but as I'm also not the expert in. I know you are in a practice where you might see different ages of patients. So I don't know if you might want to say anything. But what the person is saying, if not, then they are saying we should make sure that steps are taken to make sure that there are. But I do believe that some of them are. There is a question here from one of our senior colleagues as well, Garth Rattray. In women who do not experience any symptoms of menopause, are their health risks the same as those women who suffer from menopausal symptoms? Interesting question. Not sure if we have the answer to it.
From my reading, it's a person-to-person basis. You look at them individual by individual, personalized care. But in general, looking at it as a public health physician, the risks of. Before I answer that last piece, could you repeat the question once more for me so I get a clear answer to that, to what is really being asked?
What is really being asked? We know that some women go through menopause with minimal symptoms. Do they suffer? Would they be at the same health risk, for instance, for the osteoporosis, the other things, as those who have symptoms?
I think it depends. I think it depends on a variety of factors. One of them is race. You may remember, Dr. Stanley William, a study we did in the Bahamas that looked at the FRAC scores. One of our family medicine residents,
right,
Keisha Smith, and we found 0 of the Bahamians of African descent to have questionable FRAC scores. And the few Caucasians were the ones who we found the FRAC scores to be indicating that they were, osteoporotic or osteopenic. And that has always impressed me. And that is, that was years ago, and I know that's not new knowledge. I know most of us on this site know that it's one of the blessings that come with having come from an African descent. And the reasons are many, but I would not chance that. Certainly, if Dr. Smith was on, I would ask her to speak up on that, because that's what she got her DM on. But that also is to be weighed in. Who is your client? Is your client among the group that is higher risk for those things? And then you actually would move for that, because you would move to make those preventative measures, not just for osteoporosis,
cardiovascular disease,
but
so
other
on.
cardiovascular disease, etc.
Right.
So it's a complex decision that really has to be done with that. I would certainly, if the person qualifies for it and the person requests it, I would certainly find ways to honor that request and to collaborate with somebody who is doing this on a regular basis and would be a better guide to me. But that collaborative care would be what I would do. But
Absolutely.
I must
And
confess, I must
yeah.
confess that I am biased towards early intervention among those who are starting to see the vasomotor symptoms and who have a history of a cardiovascular nature in the family history and so forth, because there the benefits seem to be remarkable.
Right, and certainly, as you say, you would have to look at the other risk factors.
Yes.
Not because the drop in the estrogen levels, even if they don't cause the vasomotor symptoms, they would affect the other things. Yes, Dr. Brown Morgan, please come in.
Yes, I guess I just have a comment, and that is that I am with the patients I do see who are menopausal. I realize that there's some older people who tend to linger on for a very long time, and they're you wonder how to really treat these people who continue to have signs, symptoms, discomfort into their mid-70s. I have a lady right now who I saw last week. She's in her mid-70s. There is, I'm trying to remember the name, I'm sort of not remembering the name, but there is a medication which provides some, I wonder about using progesterone, or some sort of other hormone to help with the problem that she's having. I don't know what you think, Dr. Franson.
Yes, ma'am. I'm not the expert here. I must confess that from the early days, I was impressed by HRT. And then when we got the bad news about the high risk of endometrial cancer, I was not impressed with I was one of those epidemiologists who was not impressed with how we just quickly withdrew everything. And because I thought we should actually do more research, which we have done now and we continue to do, which actually speaks to a strong place for persons to get hormone replacement therapy. Persons especially who have been tortured by the transitional changes. Because for some women, it really is heartbreaking. And, if you add to that some who have succeeded in graduating from a cancer treatment for years, especially if it was, I better keep quiet on that because I'm getting into the oncologist's field now. And
well, I'm just going to come off, but I'm going to say, Dr. Franson, I have a patient who I will tell you, I have another patient, she's Caucasian. I haven't seen her in a little while because I decided to stop. She's deep depression when she doesn't get some form of hormone treatment. She's deeply depressed, but I was so afraid to keep giving it that I took it. I wasn't right anymore. I've seen her back, so I suspect she's gone somewhere else and sorting it out. But it is a problem. It is a problem.
It is. And depression itself may shorten your life way more than many things if it goes to be a strong extent and it's not. So, it's a lot of things to weigh, and the patient must be in the driving seat because they're the ones taking on the risk equally along with us, or maybe even more.
Thank you so much, Dr. Franson. Thank you so much. I also want to thank the other presenters from this session who have been answering the questions in the Q&A, but I would just give a call out if Dr. Phillips, Dr. Minot, or Professor Carpenter want to make any short last comment. I would give you a chance to do it since we're not going through your questions with you. Dr. Phillips, anything else you want to say?
Nothing really. The questions were asked. I tried to answer them. I think
Thank
someone
you
had
ever so
asked
much.
about DPP-4 inhibitors with the GLP-1 agonists, and the recommendation is that you don't use both together. I think I missed that one in answering it. So there's no added benefit, and the risk of side effects would be more.
Sorry,
So
can you repeat that? I think I missed what you
there are
said.
no added side effects. There are no added benefits, and the side effects would be greater.
Using what together?
DPP-4 inhibitors and
Oh,
GLP-1 agonists.
okay. Thanks for
Just
that.
want to jump in on the hormonal question just now. Just to say we only have Angelique, and we don't have a lot of the intravaginal preparations. We don't have the topical preparations, so definitely there's work needed for that. And for the patient, the elderly lady who was already, if she's been on hormonal therapy, replacement therapy for a long time, say, from in her 50s, the recommendation is that she can continue. Yeah, so we would not necessarily have to stop it.
Thanks very much for that. Dr. Minot, any last words from you? Okay, I'm going to take that silence as
While Dr. Minot is coming on or thinking of coming on, let me just also quickly say that I must confess that I did not use AI to do this presentation. And I'm reassured that the brain still can function without AI.
absolutely and function very well, Dr. Frankson.
I have nothing against AI though.
I think Professor Carpenter has slipped away. So I do really want to thank everyone, but that is not my portfolio. I am going to hand over to Dr. Dane Levy, who is the Honorary Secretary of CCFP Jamaica chapter, to do the formal vote of thanks.
Thank you, Aileen. A wonderful job you have done as moderator. Good afternoon, everyone. I am certainly thrilled by the level of presentations that were done by all of our presenters. Very, very interesting topic and very, very informative. But let me get into thanking everyone that participated in this second part of the Women's Health webinar, Endocrinology, ENT Ethics. The theme today was physical and mental health in women, exploring the clinical and ethical considerations. Our first moderator, of course, is Dr. Anna Brown Morgan, family physician and executive board member of the CCFP. She did a wonderful job getting us through that first half of the program. Dr. Arlene Henry Dawkins, executive board member of the CCFP as well. I think she did the prayer for us, and we want to thank her for that. Our president of the Jamaican chapter, Dr. Seni Ananuju, who brought us greetings and gave us an overview for today's webinar. Our first presenter, one of our first presenters, Professor Marshall Tuller Reed, who did advances in endocrinology in women's health, also our thyroid disorders, diagnosis and management done by Dr. Channer. Thank you both. Wonderful presentations. Gestational diabetes and reproductive endocrinology done by Dr. Leo Walker, consultant obstetrician and gynecologist. That completed the first half of our program, I think. And second half, more moderator Alien, you did that very, very well. Thank you so much. And of course, we had some wonderful presentations continuing the theme. We had obesity and metabolic syndrome by Dr. Karen Phillips, consultant endocrinologist, the impact of female sexual dysfunction on women's well-being. And because of our ages, I think we were very, very blessed by Professor Karen Carpenter's presentation. Professor of Gender, Sexuality, and Psychology. Osteoporosis, a new epidemic, was done by Dr. Mark Minot, consultant orthopedic surgeon. And of course, the final presentation was done by Dr. Frankson, pros and cons of hormone replacement therapy in women, ethics of hormone replacement therapy, balancing the benefits and the risks. I just want to thank all our presenters. I'm seeing a little note that Dr. Chanad did not present, so my apologies for thanking him, but I hope that he will soon present on our behalf one of these days. Of course, our sponsors, Merck and Medimpex, thank you so much. We are really, really, truly indebted to you for sponsoring our presentation today. We are thankful for your partnership with us, and we really want to encourage you to continue to partner with us in these endeavors. Of course, we had our administrator, Mrs. Lynn Thompson Ayat, and her team, who also were instrumental in organizing this webinar today. I'd also like to thank Samuel Heron. Sam as well did an excellent job. And Sam, you mentioned that even after COVID, we still get challenges. I think long after COVID, we'll still be experiencing some challenges. But you found a way. Thank you so much. I just want to thank also our colleagues who joined us today. At one time, I think there were over 270 participants in this webinar, and I think everyone benefited in some way, fashion, or form. And as evidenced by the questions that are asked and posed to our presenters, I'm sure that the benefits are very outstanding. I just want to also encourage our participants to join with CCFP. The benefits are there for us all. We now have an MCCFP designation that is recognized. And once you fulfill those requirements, you can use that MCC as part of your CV, as part of the qualifications that are recognized by the Medical Council. So once again, thanks to one and all. A thoroughly enjoyable morning and afternoon webinar session that we did from, because of the nature of our population, which is aging, and the challenges that we face daily in our practices. We want to just say thanks to one and all once more, and God bless you. Have a good afternoon. Enjoy the afternoon. Enjoy the evening with your families. And thanks again.
Thank you so much, Dean. And I just want to add a special thanks to Dr. Seni Ananuju, the president of the Jamaica chapter, who does so much work behind the scenes, getting us these high-class presenters for each and every webinar. Seni, it does not go unnoticed, and we know it is not easy to put these seminars together on this regular basis, and we do appreciate all that you do. And we did have over 300 people online at one time, and we thank you all. We thank the 200 odd who have remained to the end. And before you leave, if you have not already looked at some of the answers in the Q&A section, Sam, don't close the room yet, because I think there's still some very good answers in there. Take a few minutes to just look at them before you leave. All the best to everyone. God bless.